Good morning, dear doctors and healthcare professionals. It's with a great pleasure that we welcome you in this advanced radiological management in breast cancer. We are excited to bring together a group of dedicated professionals who are patients about enhancing their knowledges and skills in the field of breast cancer imaging. We are privileged to have Dr. Lubna Abdel Habib. Dr. Lobna is a professor of diagnostic radiology and breast imaging consultant at Ain Shams University, Cairo, Egypt, coordinator of the Women and Breast Imaging Group at Ain Shams University, founder and CEO of Bliss Clinic, a private clinic for breast imaging, Fifth Settlement, Cairo, Egypt. We are confident that Dr. Lubna's expertise will provide you with valuable insights and inspire of your practice. Welcome, Dr. Lubna. I hope for you a great day, and I hope you will enjoy your day with us today. Thank you so much.
Thank you very much for the introduction, and good morning, everyone, and welcome. It's a real pleasure to be here, and I hope you find this day helpful and informative to you. So I thought I'd spend my time talking about what actually we do in breast imaging. What we do is actually we look at the ultrasound, MRI, and mammographies of breast patients. And I thought that I would just explain the things we do and how we look at images so you understand how we work. Hopefully, I'll be able to cover all these objectives throughout the day. Now, breast cancer is a very common disease. In fact, it's the commonest cancer diagnosed in women all over the world. And it's expected that 1 out of every 8 women is going to get breast cancer through her lifetime. And the prognosis of breast cancer is affected by many things, such as the histological subtype, whether it's a ductal carcinoma, a lobular carcinoma, or any other type. The molecular subtypes also affect breast cancer, and we'll go into them later in this lecture. And breast cancer is also affected by a very important classification, which is the well-known T&M classification. The T stands for the tumor, which is the extent of the tumor and the degree of regional affection of the breast, the spread to lymph nodes, and this is the N compartment of the T&M classification. And also if the tumor has spread outside the breast to other parts of the body and has metastasized. So to gather this information, we step in as radiologists of breast patients, and we gather this information through diagnostic breast imaging. So how can we gather this information and perform our work? We have many techniques. The well-known and the most that everyone uses are the mammography and ultrasound. We also do contrast studies in the breast, including magnetic resonance imaging, MRI, and contrast enhanced mammography. And PET is mainly for patients who have metastatic disease. So the first thing we're going to talk about, or the first technique we're going to talk about, is mammography. And of course, it's widely available. It's absolutely everywhere. It's not expensive at all, and it's safe. It's very safe, actually. And there's been a sort of misconception going around that screening mammography and the dose of radiation that a patient can get from screening mammography can cause cancer. This is completely not right, and it's really a misconception. It's very safe to do mammographies, and it's said that the radiation dose that a patient gets from mammography can be equal to that of a 7-hour or 6-hour transatlantic flight. It's equal to the same radiation, so it's not a huge amount at all, and it shouldn't be a preventive cause of doing mammography at all. And actually, it's the only imaging modality which has resulted in a decrease in mortalities from breast cancer. And as we see here in this graph, since 1989, when mammography was developed, there has started to be a significant decrease in death from breast cancer. So we do a lot of screening mammographies. And what is the difference between screening and diagnostic mammograms? A screening mammogram is done for a patient who doesn't have any complaint at all in her breast. She doesn't have a lump, no discharge, no pain. So why is this patient coming to do a mammography? She's doing it because she's at a risk of developing a certain disease. And this risk may be as simple as just being a lady and of a certain age group. So it detects disease in a screening test usually detects disease in a very early stage so that the outcome of the disease is much, much better and we can easily cure the patient. However, a diagnostic mammogram is done for patients who have symptoms, and as we said, symptoms like she can have pain in her breast, she can have a lump, which is the most common symptom, she can have nipple discharge, and it's a problem-solving tool. It's also done for patients who have findings on screening mammograms, and we want to solve this problem. We can find something on a mammogram, and we want to see what it is, so we do a diagnostic test. Now let's look at mammographic images and see how they look. We have this white part, which is the fibroglandular tissue of the breast, and we have this gray part, which is the fat in the breast. And this is actually what breasts are composed of. They are composed of fibroglandular tissue and fatty tissue. And we take two views to image mammography. These first groups are the MLOs, or the mediolateral oblique views, and this group of images are the craniocaudal images. And on the MLOs, we have to see the muscle. These are the pectoralis muscles. You can see some lymph nodes in the axilla on the right side here. And we have to see the inferior inframammary fold to make sure that we took the whole breast till the end. And we on the craniocaudal, we have to see the nipple out. Out of profile. Okay, so it looks good and safe, and it's inexpensive, and it's everywhere. So what's the problem with mammography? We have a major problem with mammography, and this is breast density. So what is breast density? When we say that mammograms have problems with patients who have dense breast, what is breast density? It's actually the amount of fibroglandular tissue within the breast. As we see here, it's this white part that fills the breast. And not all breasts look the same. It's different from one patient to another, according to the amount of fibroglandular tissue in the breast. And we can have a fatty breast, as we said, in mammography. In mammography, we can see a gray color which represents fat, and we can see a white color which represents the fibroglandular tissue. So in this first image here, we don't see any fibroglandular tissue at all, and the image is completely gray. And this is a fatty breast, or what we say is an ACR breast density A. If we see some white now, some minimal white tissue has appeared in this image, so we have an ACR breast density B, which is a scattered fibroglandular density. And then as the fibroglandular tissue increases and becomes most of the breast, but still there's fat, because we can see white tissue here, and we can see fat at the periphery of the breast and within the fibrous tissue and within the fibroglandular tissue. So this is an ACR breast density C. And finally, when the whole breast is almost composed of fibroglandular tissue, it's almost completely white, and we get a dense breast, and it's an ACR breast density. So usually we see ACR breast density D, or the dense breast, in young patients, and we see the fatty breast in older patients, but this is not a rule. And why is dense breast a problem on mammography? It's because cancer appears white. Cancer on mammography appears white. So when we have a fatty breast like this breast, where there is no white fibroglandular tissue, then it's very easy to see the cancer. However, when we have white breasts, or dense breasts, or breasts full of fibroglandular tissue, or ACR breast density Ds, it's going to be very, very hard to see cancer when it appears white. They can be very easily missed. Now, to overcome this problem, we've started to have several tools. The first tool of which we're going to speak about today is digital mammography. And the two machines look the same. This is the conventional mammography. This is the digital mammography, and they actually do look the same. And when you ask patients, similar experience, no patient will know if she's doing a conventional mammography or doing a digital mammography. So what's the difference between both? The difference is in that in conventional mammography, the image comes out on a film, while in digital mammography, the image comes out on a detector. And once it's on a detector, it can be transferred to a computer. And when it reaches the computer, we can do many things to this image. The first thing we've done here is magnification of the image, so we can see better, especially in cases of microcalcifications, which is a very important finding in mammography. And as we see here in this image, this image, it looks completely normal to us. But when we magnify the image here, we see a cluster of microcalcification which could not be seen on the unmagnified views. So transferring images once again to the computer helps us out with this. Also, a processor is involved. So as we see, this is the digital image, and this is the digital image, and this is the conventional image. We see that the digital image is much better, higher resolution, and produces images of much better quality where we can see masses easily. Now let's see the sensitivity of mammography, and we'll define sensitivity of any test. What is the sensitivity? It's the percent of women who have a disease which this test can actually correctly diagnose. So when we say that film mammography is 54% sensitive, this means that every 100 women who have out of every 100 women who have breast cancer, if they do a mammography, only 50% of these women will the cancer be detected on, which is quite low. And when we compare this sensitivity to the digital film, we see that on digital mammography, this sensitivity equals almost 80%, which is a good percent. It's not bad at all compared to the film mammography, which gives us only 50%. So in attempt to increase our sensitivity, and another tool which we use every day and it's also everywhere and available, we have the ultrasound. So ultrasound, once again, everywhere, it's just everyone uses it, and it's a very easy, safe technique, no radiation involved, not expensive at all. We usually use our high frequency probes. The main problem with ultrasound is that it causes a lot of false positives, and we can be directing a lot of patients for biopsies, unneeded biopsies. It just detects too much, and sometimes we can't be able to clarify what this lesion is with ultrasound. And just like we said what mammography images look like, we're going to speak about what ultrasound images look like. So in this upper part here, this is the skin, and the thickness of the skin should not exceed 2 millimeters at all. Underlying the skin, the gray portion is the gray portion we saw also on mammography, and it's the subcutaneous fat. Then we have this mix of gray and white portion of the breast, which is fibroglandular tissue, and the gray things in the breast are the ducts. We have to go and see the posterior pectoral muscles on the ultrasound images, just to make sure that we haven't missed anything deep in the breast. Because if we don't see these muscles here at the back, then there may be something in the posterior portions of the breast which we can't detect. And the composition of all breasts are not the same. So when we have a fatty breast, the one here on mammography where we have no fibroglandular tissue, then of course we're not going to find any fibroglandular tissue on the ultrasound image. So this image is that of a fatty breast, and it's only composed of fat lobules within the tissue with connective tissue in between them. And when we have a glandular breast on mammography, we're going to see this white portion of the breast, the fibroglandular parenchyma, which we see here, and we won't have any ducts within it. So now we said that if fat is gray on mammography and fat is gray on ultrasound. And we said that fibroglandular tissue is white on mammography and is also white on ultrasound. So why is ultrasound better in detection of breast cancer in patients with denser breasts? It's better because this time with ultrasound, cancer appears dark. So when cancer appears dark, it's going to be much easier seen on a white background than compared to on a white background than compared to mammography, where cancer appears white and is going to be completely missed when we have dense breast or we have white breast, as we said before. Now let's talk about actually our work and what we do in our practice. First of all, we review the patient's history. We have to know the clinical question we answered, and get to know the patient and see what's the clinical problem we have. Then we systematically evaluate the images. We do our scans and we perform our scans, whether mammography, ultrasound, MRI, contrast enhanced mammography. We do our work and we have to systematically evaluate these images. And to do so, we use something which is called the ACR BI-RADS lexicon. And we're going to go into details now about these lexicons. And finally, we issue our reports with something called the BI-RADS Assessment Category Score, which comes with a recommendation and as I said, we're going to go into details of these two things now. So ACR BI-RADS Atlas, ACR BI-RADS imaging and reporting system. Everyone has heard about them and knows about them now. So what is the ACR BI-RADS Atlas? Atlas, as I said, it's an atlas with description, with a descriptor to every possible finding we can encounter during imaging. It's very important. We have now the last issue of this ACR BI-RADS was 2013, and we have an ultrasound. We have ultrasound and mammography, and MRI, ACR Atlas or lexicon. We call it a lexicon. And what its importance? It's something like a quality assurance tool. It's constant terminology, and our reports are standardized. Reduces confusion and much better communication with our clinicians and pathologists. Now when we issue our reports and we have a BI-RADS 4, 3, 2, whatever, and we don't have to explain to everyone what this means. Radiologists know, pathologists know, surgeons know. It's just sort of a common language which decreases confusion, and as I said, standardizes our reports. We have the ultrasound lexicon, the mammography lexicon, and the MRI lexicon, and we see the descriptors involved in each of them. Now, we'll begin with the mammography lexicon, and this is the whole lexicon. As you see, it includes, and we have breast composition, we have masses, we describe the masses with their shape, margin, and density, we have asymmetry, and a very important thing which we note on mammography, as I think most of you know, are calcifications with their different shapes and distribution. And finally, we have some associated features, and we go through each of them. Now, the first thing we have to comment on and report when we are doing a mammography is the breast composition or the breast density, and we've just explained that. We have 4 categories: the fatty breast, the scattered fibroglandular densities, the heterogeneously dense breast, and finally the dense breast. And we have to report this in our reports, and it's actually the term we use only for mammography. So we can't be doing an ultrasound and use these terms, and we can't be doing an MRI and use these terms. Every lexicon has its descriptors which we have to use with each exam, and it's different for the other exam. Now to mass. So what is the definition of a mass? A mass is a 3D space occupying lesion which has margins, and it has a convex outer margin. So then it's something we actually can describe. We can describe its margin, we can describe its shape, we can describe its edge. And that is what we're going to do. We're going to look into each one now. So the shape of a mass on mammography can be either one of these, and it's the same for ultrasound, the same for MRI. They won't go out of these 3 shapes. The first one is an oval-shaped mass. Oval-shaped mass is an egg-shaped mass, and we can accept in these masses 2 to 3 gentle lobulations or macrolobulations, not more than that, and definitely not microlobulations, only macrolobulations. A round mass is a spherical mass or a ball-shaped mass. And if it's not oval or round, then it's irregular. And of course, the irregular mass is the one that we are worried about always in all lexicons of the ACR. If it's not round and oval, it's irregular, which is a suspicious finding or a suspicious descriptor. Now to margins. And what are margins of a mass? Margins of a mass are the edge of the mass. And these are our options to describe the margin of a mass. So what is a circumscribed mass? It's a mass which is well demarcated, and there's fatty tissue all around it, so we can go all around the mass like with a pencil. And an obscured mass is a mass that we can't see all the edge. This is because it may be superimposed by fibroglandular tissue, so the whole margin of the mass is not seen, and we use the term obscured. It can also be microlobulated, and what is microlobulated? It's small cycle undulations, and it's quite suspicious with mammography. And finally, indistinct. Indistinct means that even a small portion of the mass, we cannot define its edge. Not all the mass, even if not all the mass, if you can see the whole margin of the mass, but there's a small portion of the mass which we cannot see, then this is described as an indistinct margin. And finally, the speculated margin, where we find white lines extending out from the mass, and this is the most suspicious of them. And usually when we get speculated masses on mammography, this is a malignant mass, very high positive predictive value for cancer. Now to mass density. So we said 3 descriptors for a mass: the shape, the margin, and on mammography we describe the density of the mass, which is comparing this mass to the fibroglandular tissue in the breast, adjacent breast parenchyma. And we have a fatty density, which is just like fat. It's gray, as we said, fat is gray on mammography. So a fatty mass will appear just like fat. We have a low density mass, so it's less than the adjacent fibroglandular tissue. We have an equal density mass, which means that it is just like the adjacent fibroglandular tissue. And we have a high density mass, which is higher than the fibroglandular tissue. And of course, high density mass is the most suspicious of them all. And we very, very rarely find cancers, or we don't find at all cancers who are of fat density on mammography. These are usually benign lesions. Now we finished mass, and we're going to talk about the descriptor, which is asymmetry, and it's quite unique to the mammography lexicon. So what is asymmetry? Asymmetry is unilateral deposition of fibroglandular tissue. So instead of finding fibroglandular tissue in both breasts, like all the images we've seen till now, we'll find the white fibroglandular tissue in the breast just on one side and not on the other side when we compare both sides. So we have types of asymmetry. We have just asymmetry. And this, as we said, there is a unilateral deposition of fibroglandular tissue. This is the fibroglandular tissue, the white portion of the breast. And as we see here, it's only seen in one side of the breast. When we compare it to the other side of the breast, it's not seen. And asymmetry is seen on only one view. We have the MLOs up here, and we have the craniocaudal images are at the bottom of the image. And we can see this white tissue only in the upper image. So then we describe it as an asymmetry, and it's usually nothing to worry about. It's just a superimposition of a tissue, and the better compression with craniocaudal images will make it fade away. Now to global asymmetry. This time we see that the fibroglandular tissue in the breast involves the whole breast. And once again, as I said, since it's unilateral deposition of fibroglandular tissue, when you compare it to the contralateral side, the right breast compared to the left breast, you see that the density of the right breast is much, much higher than the other side. So we have a global asymmetry in the left breast, and it's usually a normal variant. Once again, nothing to worry about. Now to focal asymmetry. We're starting to worry now from focal asymmetry. And why didn't we call this a mass? We didn't call it a mass because it doesn't have the convex outer border that masses usually have. Instead, the outer border or the margin is quite concave. And we also have fat within the lesion. As we can see here, it's not completely white. We have gray fat within the white tissue. So we say that there is fat interspersed within this lesion. And it's seen on both views. We can see it on the mediolateral views up here, and it's also seen on the craniocaudal views down here. So what do we do when we find the focal asymmetry on mammography? It goes for follow-up. Follow-up means that this patient will come to us again after 6 months, and we want to see what happened to this asymmetry or unilateral deposition of fibroglandular tissue on this side, and we can get a developing asymmetry. So what is a developing asymmetry? It's the focal asymmetry we saw, but now it has become larger and it has become more conspicuous than it was on the other images. And we have a general rule in the breast which says that anything which becomes larger or becomes more conspicuous, it just has to go for biopsy. No matter how benign I feel this lesion is, once this lesion has increased in size and once again has become more clear and we can see it better, more dense, and this lesion just has to go for a biopsy. So the worst one of them, or the one with the suspicious features, is the developing asymmetry, and it's usually biopsied, and sometimes it can be really worrisome. Now to calcifications. Calcifications, of course, is a unique, important descriptor in mammography, and we all know that microcalcifications can imply that there is underlying cancer in the breast, and it's not seen, and it's not seen on any other examination, and best seen on mammography. So we'll go into details of calcifications, and they are classified according to their morphology and to their distribution, and let's look at them. So according to morphology, we have typically benign calcifications and we have suspicious microcalcifications. And the typically benign calcifications are the calcifications we can very easily detect on the mammography, and we don't have to do anything about them. We completely ignore them. And there are several types. First one of which is the vascular calcifications, which are tram-like or parallel lines. They are associated with blood vessels, and we see it usually in patients in older patients. We don't have problems regarding vascular calcifications at all, and we're pretty sure this is something benign. Skin calcifications have radiolucent centers, as you see here. Also, something pathognomonic and something we don't worry about at all. And the well-known popcorn calcifications seen in an involuted fibroadenoma. Well, in fact, it's a very good sign. It's not worrisome. On the contrary, when we see a fibroadenoma with the calcifications, we know that it's involuting, and we can just ignore it completely. Rod-like calcifications, it's not worrisome, and it's just a short rod appearance calcification. No problem with it at all. The next one is the round or punctate calcifications. And you can see a common feature between all these calcifications, and it is that they are microscopic calcifications. We can see them very well. Anyone can detect them just looking at a mammography. We don't have to magnify the images to see them. So we're safe as long as we can see them without magnification, and they're easily detected on a mammography film, and we're definitely safe, and we definitely have benign calcifications, and we're not worried about them at all. Now to rim calcifications, which is usually calcifications in the wall of cysts, and we can also see it in fat necrosis, so in the oil cysts. Dystrophic calcifications, large irregular calcifications related to the scar tissue in breast or in irradiated breast. Milk of calcium. The milk of calcium is sedimented in cysts. We can see it layering down here in the cyst. And finally, suture calcifications. It's calcifications on the suture material in a post-operative breast, and sometimes we can see the knots. Now we've finished the typically benign calcifications regarding the morphology. Let's look at the suspicious calcifications. And again, I'm speaking about the morphology of the calcification, how they look like, their shape, and we're going to go after that to speak about the distribution of calcifications, which is a very important factor too. So suspicious calcifications according to their morphology and shape include amorphous calcifications. And what do we mean by amorphous? We mean about amorphous that it's too small and too hazy to define their shape. We can see something faint. We can't see its shape. It's very, very ill-defined and very, very hazy. We can't determine its shape. We have the coarse heterogeneous calcifications. These are large calcifications, and these are the least worrisome of all types of suspicious microcalcifications. They resemble dystrophic calcifications, but as we said, the dystrophic calcifications are seen related to a surgical scar or to a previously operated breast, previously radiated breast. Of course, heterogeneous are seen in a non-operated breast, so they're sort of worrisome, but they are the least worrisome of all these. And then we have the fine pleomorphic calcifications, and we're starting to get worried now because these are the descriptors that we don't like at all. So what does a pleomorphic mean? Pleomorphic means different size, shape, and density, okay? Once again, when we say fine pleomorphic calcifications or fine pleomorphic microcalcifications, we mean that they are different in their shape, in their density, in their size. And we definitely won't be able to detect these calcifications on a non-magnified view. So if you're looking at mammography and your mammography films, and you don't magnify your films, and you don't magnify your images like we saw earlier in this in the lecture, then you're definitely going to miss suspicious microcalcifications like these microcalcifications, which we definitely don't want to miss, because as I said, we're moving towards the suspicious microcalcifications now, and fine pleomorphic calcifications or microcalcifications is something which we really worry about. And to our worst calcifications ever, the fine linear or the linear branching calcifications. And as we see, these are small lines of calcifications. Calcifications at the end are white dots of calcification seen in the breast. Here it's like a very small lines of calcification, and we can see some of them branching. And this is the microcalcification with the highest positive predictive value for malignancy, and it can be almost 70%. And as I said, and I want to repeat again, anyone who's looking at mammography films without magnifying these films is going to definitely miss these types of microcalcifications, which we don't want to miss. As I said, their positive predictive value for cancer is quite high. Now, just as morphology is very important, the distribution of the calcifications within the breast is also very important. So we have diffuse calcifications, which are widespread all over the breast, and usually we don't have anything to worry about. We see it on the other side of the breast too. It's just calcifications within cysts. Regional is calcifications involving 25% of the breast in a certain area. So when we see it, we prefer to look at the morphology and decide whether we have suspicious calcifications or not according to their morphology. But these two are usually not something to worry about. Now to group calcification. What is group calcifications, or what do we define as a group or cluster of calcification? It's calcifications within maximum 1 millimeter, small area of 1 millimeter. And once again, definitely won't be seen if we don't enlarge our images or magnify our images and see it. And this is a suspicious microcalcification or a suspicious descriptor of distribution for calcifications. And now we're moving towards the more suspicious ones, the linear calcification. And these microcalcifications or calcifications, if we get a ruler and we put it, so it will follow the line of the ruler. And of course, this represents a ductal distribution, and it can occur because of malignant cells filling the duct. And we're very worried about these sort of microcalcifications when we see them on mammography. And the worst of them all is the segmental calcification. So what do we mean by segmental microcalcification? We mean an area of microcalcifications. It can be triangular shaped, usually triangular shaped, with the apex of the triangle pointing towards the nipple. And this carries the highest positive predictive value for malignancy. It can reach almost 70%. And it's the worst type of microcalcifications we would like to see. So what does microcalcifications imply? It implies that we might have a region of ductal carcinoma in situ. It's seen with a high percentage of patients with DCIS, and it's usually quite a problem for us. Okay, so we're still in the lexicon of mammography, as we said, for those who came in late. What we mean by a lexicon is an atlas with the descriptors for any finding we encounter in breast imaging, and we're discussing now the lexicon concerned with mammography findings. And now we'll move to the last descriptor here in this lexicon, which is the associated features. So on mammography, you can have an area of architectural distortion. And what does that mean? It includes a straight lines and distortion of the parenchyma without actual mass being there in the breast. So we don't have a mass, all we have is some sort of distortion in the parenchyma of the breast. You can see here white lines, and we don't have a mass. It's something quite suspicious when we see it. If we don't have an appropriate history, then we're worried about this sort of finding. And now to other associated findings. We can find skin retraction. In this image, we usually see this kind of image with patients who have been post-operative or operated upon before. And they give us here we can see the line, the dense line of the skin is just one line. And down here we have another line, which is the double skin sign.
بس الصوت شوي مش واضح فاحنا اسفين على المشكله هاي. يعني ممكن عوض بعد اذنك نستعمل هذا المايك.
No, no, no. I don't want to use.
سوري. بس
بس
لانه كلها عم بيقولوا
I'm
لي
happy with
الصوت.
this. Something, something.
شغال.
I can't hear it.
I don't want to.
Can you do this one, please?
I'll try to do it and hold him. So I don't want to hold it in my hand, definitely. I hate holding it. Can you try to do this one, please?
سوري بس لانه كانت في كمان كان هذا الموضوع اسفه اطلع.
No problem. I want to solve the problem, but I don't want to hold this.
Okay, so are we better now? صباح النور. Okay, I'll repeat. Okay, I will. So are we fine now? Better now? Reduce what? Reduce.
reduce the نعطيه شوي.
Okay. Are we okay now? Better? Fine or not? Fine? And I don't have to hold this. Important.
Sorry, this was
No problem, no problem. No, I can't. I don't want to hold it in my hand. Okay, are we okay now? So do you want me to go quickly through which part exactly? Excuse me? Calcifications. Okay, great. So we're not from the beginning. Okay, we'll go through the calcifications again. It's good. We can remind ourselves with them. They're very important. Okay. So now we'll repeat the calcifications, and as I said, it's something unique and very important in the mammography report. And we describe calcifications in the breast in two ways. We describe their morphology and we describe their distribution. So not all morphology is suspicious and not all distributions are suspicious. Let's look at them one by one. We have typically benign calcifications according to their morphology. These are the calcifications which we easily see on mammography film, and we're not worried about them at all once we see them. They are quite pathognomonic for each pathology. We have vascular calcifications, which are tram-like calcification, and these are associated with blood vessels, very common in older patients. We have skin microcalcification, and these are characterized by their radiolucent center. Once again, benign calcifications. We know what we're seeing, no problem with them. We have the popcorn calcifications. Everyone knows popcorn calcification. It's large calcifications within the dense lesion we see here, which is an involuting fibroadenoma. And in fact, sometimes we can worry about having fibroadenomas. Some fibroadenomas don't have typical features, but when we see these involuting fibroadenomas, we're very confident that we don't have problem at all, and it's a real comforting sign. We have, thank you. We have rod-like calcifications. We have round or punctate shape, rounded calcifications. We have rim calcifications, which are calcifications in the periphery of cyst. Dystrophic calcifications, these are related to surgery or previously irradiated breast, and as we can see, they are large calcifications. We have milk of calcium sedimenting in cysts. And finally, suture calcifications, which is calcification deposited on suture material and can take shape of the knots that are there. And these are very pathognomonic calcifications. And what is common in all of these calcifications that they are macrocalcifications. They are calcifications which we can very easily see on mammography. We don't have to magnify the image to see them. So we're definitely in a safe place. And now to the suspicious calcifications or suspicious microcalcifications. We have amorphous calcifications. And what's the meaning of amorphous calcifications? They're too small and hazy to define their shape or to define their size. We barely see them, and these are quite worrisome. We have coarse heterogeneous microcalcifications. They look like the dystrophic calcifications, but they're smaller in size, and they're seen in the non-irradiated breast and the non-operated breast. We have to follow these type of calcifications. Now, the worrisome types, we have fine pleomorphic calcifications. And what does pleomorphic mean? It means that they have different shape, different size, and different density. And as I said, these are calcifications which cannot be seen on a non-magnified film or a non-magnified image. Or if you just hold a mammography film with no attempt to magnify, and or even if with a magnifying glass, you're definitely going to miss these microcalcifications. And now to the fine linear or linear branching calcifications. They look like small lines, and we can have branching. We can have some branching calcifications in these, and these are the worst calcifications. And what do they imply? Microcalcifications most of the time represent ductal carcinoma in situ. They usually are seen as fine pleomorphic or fine linear or linear branching microcalcifications, and these are calcifications that have to be biopsied. They cannot be left for follow-up. And just as we have suspicious calcifications according to their morphology, we also have suspicious microcalcifications according to their distribution in the breast. We don't only look at the shape of these calcifications, we look at their distribution in the whole breast and decide whether this is a suspicious distribution or it's just a normal finding. So the first descriptor of distribution of calcifications within the breast is the diffuse calcification. We see it in the whole breast. They are usually bilateral. They can happen in cysts most of the time, and it's not something to worry about at all. Regional calcifications, they're in a certain quadrant of the breast, less than 25% or less than a quadrant of the breast. Once again, we usually don't worry about them. We prefer to look at morphology of microcalcifications when we see this sort of regional microcalcification. And then there's the group microcalcifications or cluster of microcalcifications, as you all have heard this term before. And what does cluster of microcalcifications mean? It means calcifications, and usually suspicious microcalcifications in a very small area which does not exceed 1 millimeter. And once again, looking at a normal non-magnified mammography image would definitely not detect these suspicious microcalcifications. Now we're moving towards the more and more suspicious microcalcifications regarding their distribution, and we have the linear microcalcifications. So what are linear microcalcifications? If we get a ruler and put it on these calcifications, they're going to take a straight line. And of course, this represents a ductal distribution and usually representing malignant cells filling the ducts, the ducts. And then the segmental distribution of microcalcifications, which is a triangular distribution of calcifications with the apex of the triangle pointing towards the nipple. And this is the most highly suspicious distribution of calcifications. And it has a positive predictive value of almost 70%. And as I said, all these microcalcifications are commonly associated with a ductal carcinoma in situ. And they're very commonly the only presentation of DCIS. Patient doesn't feel anything. There's just some suspicious microcalcifications. She can't see them. She can't feel them. The surgeon can't feel them too. So this is why we do mammography, to detect these very early and detect them in the stage of the in situ stage before they are invasive ductal carcinomas. And to our last descriptor, associated features, we not only look at masses and calcifications, we look at associated features which can be there alone or can be associated with other features that make us suspect that we have breast cancer or are worrisome for us. The first of which is the architectural distortion, and it's the distortion of the normal parenchyma of the breast. We can see these white lines coming from a very small density, which cannot be a mass. And a mass, once again, is a radiodense mass, which has a radiodense lesion, which has outer convex borders. With architectural distortion, we don't see this at all. We just see distortion of the parenchyma, and it can imply malignancy. Other associated features which we look at are skin retraction, very common to see in operated breast. in operated breast, and we usually see skin as a thin white line at the edge of the breast here, and up there it's just one line. However, when we go to the lower part of the breast down here, the one line now has become a second line, and we call it the double skin sign, which is seen in operated breast. As I said, we can see nipple retraction, and a lot of times I would go in and go to speak to my patient, and I ask her about nipple retraction because it's one of the worrisome symptoms in breast cancer. And she would tell me and assure me that this is something that has been with her for years and it's not something new. But once this symptom is said in a new patient, we have to look for malignancy. And as we see here, the nipple is retracted inside. Here's the skin of the breast, the white echogenic line, and now the nipple is innermost than the skin, and we have a irregular speculated mass pulling this nipple inside. Skin thickening. We said that the skin is a thin white echogenic line at the edge of the breast. Now look at this white line here. It's much thicker, and we can see this in many scenarios in the breast. Of course, if the patient has had previous radiotherapy is one of the causes of this thickened skin. It can also happen with inflammatory breast cancer, can happen with congestive heart failure, it can happen with a large axillary burden lymph nodes compressing the lymphatics and causing this. So several factors affect the thickness of the skin on mammography, and it's a factor which we have to concentrate on. As I said, it might imply inflammatory breast cancer, which is one of the advanced cancers in the breast. Cannot leave it like this. We have to follow it up and get a detailed history to understand why we have this skin thickening. And usually skin thickening is associated with trabecular thickening, which is thickening of these ligaments in the breast. We have two breasts here, this one and this one. So we have the left one and the right one. So which breast would you think is abnormal? Look at it and tell me. Which one? The right breast? Yes, the right breast. What do you think? Why is it abnormal compared to the other side? Tell me what's abnormal about it. You said abnormal, so you have to say why. What do you think? Anyone want to comment? I can't hear. The left or the right? This is our right breast. This is our right breast, and this is our left breast. So which breast do you think is abnormal? The left is abnormal. So who thinks the left is abnormal? Architectural distortion in the right side. What else? Okay, so we want to see who thinks the right, who thinks the left. Right breast. Who votes for the right breast? Who votes for the left breast? Who votes for no breast with a completely normal breast? Okay, so when we compare both breasts together, the first thing we want to look at about is the thing at the periphery of the breast, which is the skin, and look at this thin pencil-like skin on the left side and compare it to the other side. What do we have here? Definitely this on the right side is not similar to this on the left side, right? Are you okay? Do we agree on this? So we have this thin pencil-like white line, which is almost not seen on the left breast. And when we compare it now to the right side, look at the skin thickening. Can you see this thickening here? Okay. And then let's look at the reticulations of the breast. Look at the left breast. We can see very thin reticulations here. These thin white lines, framework or fibrous network of the breast. Now look at these lines here. These lines are definitely thickened. Okay, can you appreciate the difference now between both? So we have a problem in the right breast, as you said, those who choose the right breast. We have skin thickening and we have trabecular thickening, and they're very commonly associated with each other. And most of the reasons are similar to those which cause skin thickening. They are the same causes of the trabecular thickening, whether inflammatory breast cancer, the worst of them all, the congestive heart failure, previous radiation to the breast, and now to axillary adenopathy. It's seen on the muscles. We said that up here, these are the pectoral muscles, and here are the lymph nodes, and it's something very important in patients with breast cancer. and we have a better tool for assessment of lymph nodes. And the best tool for assessment of lymph nodes with breast cancer is ultrasound, and we're going to go into details of assessment of lymph nodes with ultrasound later on in this lecture. Now we finished all our descriptors for mammography. We're not supposed to find the lesion on mammography, which we cannot use these descriptors to describe. And as I said, each descriptor is going to be described according to this lexicon to standardize our terminology, and we don't want to use anything out of this ACR. And they really have done a good job. They've covered almost everything we see. So we just have to use it, okay, in our descriptions. We don't want to see reports with something that we haven't read or said in this lexicon. We should stick to these descriptors. And actually, we don't see in our practical work anything outside of this atlas or outside of this lexicon. So to our next lexicon, ultrasound. So as I said, ultrasound, it's everywhere, it's available, it's cheap, no radiation is involved, and it's just maybe the best tool for everyone to use. Of course, it's not the best as a predictive value in detection of breast cancer, but it's very, very easy and it's very safe, and once again, it's available everywhere. So this lexicon includes things similar to the mammography lexicon. We have different descriptors. We'll go into them now. And the first thing, just as on mammography lexicon, we have to comment on the breast tissue composition. And similar to mammography, we have homogeneous background echo texture. And what does this homogeneous background texture mean? It means it's a fatty breast, because again, we see only fat lobules. We now miss the white portion of the fibroglandular tissue seen within the breast. We have the skin, this echogenic part of the image up here. And then we have the gray fat lobules. We don't have fibroglandular tissue at all. So this is homogeneous background echo texture or fatty breast. And we can have this homogeneous background echo texture as a fibroglandular parenchyma, and the difference between both is seen. Here we have fat lobules, but in this image, instead of the fat lobules, we have this white parenchyma or this white fibroglandular tissue. And we can have a heterogeneous background echo texture, and this is actually what we see most of the time. It's a mix between fatty and fibroglandular parenchyma. We have this white part. This time it's not completely white, but we have fat in between and ducts in between. And the white part is the fibroglandular tissue, and these dark parts are the fat and the ducts in the fibroglandular tissue. Now the mass descriptors, and they're a bit much more than those we use for mammography. We have things in common, but we have other things we describe when we see ultrasound or perform ultrasound on our patients. Once again, mass is just like mammography. Oval masses are egg-shaped. We can accept 2 to 3 gentle macrolobulations, not microlobulations. A round mass is a spherical or ball-shaped mass, and an irregular mass is a mass which is neither oval nor round, and this is a suspicious finding in all lexicons, as we said before. Now, something new with ultrasound, we have the orientation of the mass, and the relation of the mass to the overlying skin, whether it's parallel or not parallel. So a parallel mass is a mass, the long axis of the mass is parallel to the surface of the skin, and this is usually a benign finding. We see it in a lot of benign masses. And we have the non-parallel masses, which we usually say in our common language is taller than wide, and it's not parallel to the surface of the skin. It can be even perpendicular. The long axis of the mass, as we see here, is not parallel to the surface of the skin. It can even be perpendicular to it. Now the margin of the mass, and once again we have some more descriptors which were not seen on mammography. We have them only on the ultrasound lexicon. Circumscribed mass is a well-demarcated mass. We can get a pencil and go all around the mass. So we're not worried about this kind of mass. We have an indistinct margin. So what is an indistinct margin? It's a margin which is too hazy for us to define what it is. As we see here, it's just hazy. We cannot say what type of margins we have here. So we just use the term indistinct. And there's the microlobulated margin. The microlobulated margin involves small cycle undulations. We can see here, and this is quite of a suspicious finding. You need to know it to see it. If you don't know it and you haven't heard about it, you're not going to use this descriptor. So put it in mind because it's very common to be related to a suspicious finding in the breast. Once again, small undulations. These are not like the large microlobulations, which we said we would accept in any oval mass. If an oval mass has three macrolobulations, it's no problem, and we're still in the oval category, we're still in the benign category, we're still not worried. But when these lobulations are microlobulations and short undulations like this, it's a suspicious finding, and most of these lesions with these borders go for biopsy. And we have in the not circumscribed masses, we have angular margins, which are sharp corners in the mass. Definitely suspicious. We can see here, this is not a smooth mass. We have a sharp corners in this mass. And finally, just like mammography, the speculated mass, which is the highly suspicious mass, or the highest suspicious mass. And this time, the lines which radiate from the mass are going to be dark in color, not white like on mammography, because we said that cancer on mammography is white. So definitely lines going out of a mass in mammography, they're going to be white, while cancer on ultrasound is dark. So lines going out or speculation going out from a mass this time are going to be dark. Now to the echo pattern of a mass, and this is a descriptor which is unique to ultrasound, and it's the comparison of the density of the mass or the echogenicity of the mass to the surrounding fibroglandular tissue. So we have anechoic masses, which means no echoes inside. They're completely black on ultrasound. We don't have anything in these lesions at all, and they usually imply breast cysts. We have hyperechoic masses, and take care or note that this time we use the term echogenicity with ultrasound. We use density with mammography. We use echogenicity with ultrasound. So we can't say that we have a hyperdense mass on ultrasound. This would be a wrong descriptor. What we can say is that we have a hyperechoic mass, and it means that its echogenicity is higher than the surrounding fibroglandular tissue. And this is usually fatty lesions, and nothing to worry about at all, completely benign lesions. Here is the lesion. And now we have an important descriptor, which is a complex cystic and solid lesions. So what is a complex cystic and solid lesion? It has a part of the lesion which is cystic, this part here, which is black. This is the anechoic part of the lesion, and we don't worry about this at all. But we have something here which is almost isoechoic or hypoechoic to the fibroglandular tissue. And what made us say that this is actually a complex cystic and solid lesion? What do you think made me say here that this is actually a solid component? No? Excuse me? Dr. This lesion here, I'm sure this is a complex cystic and solid lesion. Why do you think I'm pretty sure it's complex cystic and solid? Why do you think in the image? Look in the image. Yes. You want to say something? I am not radiologist. Not radiologist. Okay. Excuse, I can't hear you. We take in consideration yes. If the ovarian have some area. Yes. Great. How do you say in gynecology? We all speak the same language. Well, how do you say in gynecology that you have a solid lesion in an ovarian cyst? How do you say it? What makes you expect that you have this? What in ultrasound? What is ultrasound? No, not who said hyperechoic, but it's hyperechoic? Okay. The pillar shape, which, okay, so good. I like the discussion. It's opening things up. So as I said, we all speak the same language. Gynecologists speak the same language. It's all breast disease, and it's all pathology and medicine. We suspect ovarian or breast cystic, complex cystic and solid lesion because of just one thing, which we said here. We have flow, we put Doppler on, and we have positive flow. Okay, so here we can see the positive flow. It's the red color here, okay, in the lesion. And this equals a solid mass, okay? Once you see positive flow in any cystic solid mass, intraductal mass, whatever, this equals a solid mass. and a solid mass equals biopsy. Okay? So Doppler just changes our management. Doppler just changes our management completely, and this is why I widely advise not to do any breast imaging on an ultrasound machine which does not have appropriate Doppler settings, because it changes my diagnosis completely, it changes my biorads completely, and it changes the management completely. Okay, and it's diagnosed by just a single thing. Once I see vascularity within a lesion, whether it's cystic, it's a cystic lesion, I see vascularity, whether it's a duct, I see vascularity, it just changes my diagnosis, and this is an important diagnosis. I can never leave a complex cystic and solid mass without biopsy. I can never leave a mass within a duct with flow where I put my Doppler on. Just something very, very simple, very, very simple tool. I just turn my Doppler on and I see color inside this mass or inside this cyst. I just have to go for biopsy, and a lot of times the results we're getting from pathology, they can be benign, okay, but a lot of times they are not benign at all. So, yes, yes, but this is a different, we have several types of cysts. We have several types of cysts. We'll talk about it. We have simple cysts like the one we saw here. This is an anechoic cyst. We don't have anything inside the cyst to put Doppler on actually. So this is a simple cyst. We don't do anything. It's a completely benign diagnosis. Takes a BI-RADS 2, IRAD 2, but this is a cyst too. This is a cyst, but it's a different type of cyst. So we see the anechoic part of the cyst. So we know now that we're speaking about cyst. We have behind the cyst usually posterior acoustic enhancement, but we have something isoechoic inside this cyst, and we need to investigate what it is. So we just put Doppler on to see, is it just echoes and it's just a source of infection within the cyst, what would we call a complicated cyst, or if we have positive flow, and now we have, as I said, a solid mass, which is something we have to comment on. Okay? So it's a very important note, and as I said, when we're working, we just have to do a Doppler examination for anything suspicious or anything we want to see if this actually is, there is flow in this lesion or not, and proceed with this lesion to biopsy. So hypoechoic lesions, most of our lesions on breast are hypoechoic. It does not imply malignancy. Of course, malignancy is hypoechoic, but fibroadenomas are hypoechoic. It's nothing specific to malignancy, and the margins of the mass are much, much more important than the echogenicity. Isoechoic lesions. So what are isoechoic? Hypo, of course, is less than the surrounding fat, and in ultrasound we compare the echogenicity to the fat this time, not to the fibroglandular tissue as we do on mammography. We said when we compare densities on mammography, we will compare the density of the mass to the fibroglandular tissue. But on ultrasound, the echogenicity, the term is different now. We don't use, as I said, density, we use echogenicity, and we compare this echogenicity to the fat in the breast. So isoechoic, this is an isoechoic lesion. We can see the fat lobules surrounding it, and it's completely similar, and the lesion does not stand out because it's just like the surrounding fat lobules, and it can be anything, benign, malignant. We just have to further investigate. And the last one of the echo patterns of the masses that we can see on ultrasound is the heterogeneous echo texture, or heterogeneous echogenicity, or the heterogeneous echogenicity with the mixed echogenicities. We can see some hyper echogenicity within this lesion. We have areas of hypoechogenicity, and it does not imply any suspicious finding. Can be benign, can be malignant. As I said, once again, the margins are the most important. Yes. Well, I don't want to say for follow-up or take a decision, as I said, or take a decision about it. I'm going to look at other descriptors, and this is what we do. When we assess a mass on ultrasound, on mammography, or whatever, I cannot make my decision. And what is this decision we're making? It's the BI-RADS category score we want to put at the end of our report. So I can't put this BI-RADS score on just one finding. I have to think of all the findings I have, and usually we put it on the most suspicious finding. So if I have a heterogeneous echo texture, if I have a heterogeneous echo texture, and the margins are well circumscribed, I have no problems, I have no microlobulation, so it's definitely going for follow-up, or it's a benign lesion. But when I have this heterogeneous echo texture in a lesion which may have irregular margins or microlobulation, it's going for biopsy. So it's not definite. We assess all the descriptors that we've discussed, and it's our role at the end of the day to put the proper category for these lesions. Now the posterior features of the mass. What are the posterior features? And again, a unique feature for ultrasound. It's the features or what we see behind the mass. So we have no posterior features. We can have lesions not showing anything behind them, as we see here. This one has nothing behind it. Now compare the first image with the second image. We have something white behind these lesions, and this is enhancement. We have posterior acoustic enhancement, and it's usually common with cysts. And why is that? It's because the fluid in the cyst enhances the flow of the sound waves coming from the ultrasound probe. So we see them as a white area behind the cyst, and it's one of the descriptors which makes us very confident about describing the cyst and knowing that there's nothing to worry about it here. And shadowing. So instead of the white area that we see here in the cyst, we see dark areas or a black area behind our lesion. And this is because the sound waves have been impeded by this sort of lesion. So it's definitely a solid lesion, and most of the time it's worrisome, and we're worried about this kind of shadowing. And finally, the combined pattern, where here we can see some enhancement. Here is a bit of enhancement, and then we can see some shadowing. And the combined pattern is very, very common with lesions who have calcifications, because calcifications are things that cause shadowing. So we can see this the combined pattern with the lesions who have calcifications in. If a cyst has some sort of calcification in it, we'll see the cystic part of the lesion showing enhancement, but the part of the lesion with calcifications in will see shadowing. And when we come to describe this lesion, we say that it has a combined pattern of posterior features. Now to calcifications. So is calcification that important on mammography, on ultrasound like mammography? Of course not. And we're not into describing calcifications on ultrasound at all. Several times I can be in my work, and then younger staff can say, this mass has calcifications and we can't see it on mammography. So I tell them we definitely go for mammography. It's not an ultrasound, because sometimes the fibrous septa of the breast can appear as if they are calcifications, and they can cause some shadowing. It's not displaced, as I said. If it's obvious, okay, we comment on it. If it's not obvious, then it's left for mammography to do this. And it's very simple. It's not even comparable to the description of microcalcifications on mammography. We have three types of calcifications. We're definitely not going for morphology or going for distribution. We're just going to say if we see calcifications within a mass, and here in this image we can see these small white flecks of calcification. So we say that we have calcifications in a mass. Calcifications can be outside the mass, like we see here. This is the mass, and now we have some dots of calcification outside this mass. And finally, and the most worrisome, is the intraductal calcifications, but it needs very high resolution ultrasound machines to detect these things. And the intraductal calcifications, once again, imply that we might have ductal carcinoma in situ, and it's highly suspicious. Now to associated features, like we have architectural distortion on mammography, we also have it on ultrasound, but of course the appearance on ultrasound is different, and we have an area of shadowing. Once again, we try to look for a mass. Is this area of shadowing related to a mass, or it's not related to a mass? We don't see a mass. We don't see a mass. And mass again is a 3D space occupying lesion. So to say that we have a mass on mammography, on ultrasound, on MRI, and whatever imaging we're doing, we have to see a lesion with a 3D space occupying lesion. We can describe its modeling shape. So we definitely don't see this here, but we see some distortion in the surrounding parenchyma. Once again, this framework is not the normal what we see, and there's no mass. It's a suspicious finding. Ultrasound is also good at looking at ducts, which mammography doesn't do very well. So this is a place where ultrasound is much, much better. And we can see here ducts normally are wider towards the nipple, and as we go into the breast, they get thinner. So we can see it here. We have dilated ducts They are much, much larger than the caliber that we normally see. And here we have cystic dilatation, and we have something inside. Something seems to be there inside the ducts. We have dilated ducts here, and something appears to be there. And how can we confirm if there is something there or not? I'm quite suspicious about this lesion, and I want to know what I can do about it, just to say if we have a mass or not. Yes, I just said it. We just said it, okay? So once again, when we have something suspicious, we just put our Doppler on and we'll see if we have actually vascular flow within this lesion, and it will change once again our management. So from isoechoic content, just debris in the ducts or dilated ducts, the ductal ectasia, we're going for an intraductal mass, which is quite of a serious diagnosis. And as I said, we have to proceed for biopsy once we have flow within ducts or we have a mass. Associated features once again, skin thickening, and on ultrasound we see that skin thickening, it's the echogenic lines we saw before. So what is the upper limit we can accept in ultrasound? It's 2 millimeters. This is more than 2 millimeters. So we definitely have skin thickening and skin retraction. Skin retraction, we'll see it that the skin, the lower layer of the skin is separated from the upper layer of the skin. This happens in post-operative patients with fibrosis, and we see a lot of shadowing behind the scar tissue, or as we see in this area. So it's common with the post-operative patients. And now to edema of the breast, associated features and edema of the breast. We have a right breast and we have a left breast. Once again, we're going to vote for which breast is the abnormal breast. You have a right breast and a left breast, so take several minutes to think about it, and please tell me which side you think is the abnormal breast. Okay, so we'll vote for the right. Who thinks the right breast is abnormal? Right abnormal. Can you do this? I want to see how many. 3. Who votes for the left breast is abnormal? Who doesn't vote? Everyone. Okay, so let's compare both sides to see which side is abnormal. We said that we have to look at the structure of the breast on ultrasound, and we'll decide now which is the abnormal breast. So let's look on the left side. This is the echogenic lines of the skin. I think we're in normal dimension or normal caliber. And then after the skin, what do we see? We see the subcutaneous fat. We said it's gray on ultrasound, fat lobules flowing into each other. So I think this is what we also see on this left side. And here we can clearly appreciate that we have muscles in the posterior part of the breast. These are the striations of the muscles. So our sound transmission is going through till the back of the breast, and we can see our muscles on our image. So I think we're normal here on the left breast. Let's look at the right breast and comparing to what we just said on the left breast. Now, the echogenic lines here, this is the echogenic lines. What about them? Thickened, of course, they're thickened, and they're not clearly seen as well. We can here clearly demarcate the white line from the underlying subcutaneous fat. But on the right breast, it's thickened. We can see a part of it and make sure that this is thickened skin, but it's not clearly separated or clearly demarcated from the underlying fat. And why is that? It's because the fat lobules contain edema in them or have fluid in them. And this makes the lobules look bright. And when they look bright, instead of being gray like this, and there's a demarcation of the breast, we see that they are now bright and they are almost inseparable from the skin. We cannot separate our layers well, like we can see in the left breast. And we almost say that this is a featureless breast because the layers are not really identified, and it's because of the edema. And this edema can impede the passage of the sound waves, and we can't see the muscles at the back of the image like we can see here in the left breast. Here, I can't clearly identify the muscles. We can't see the linear striations of the muscles, and we can actually miss a lesion in the posterior part of the breast. So what can we do to see the breast properly if we can't see it with our ultrasound? I can't see the back of the breast, and this is very important because I can very simply miss posterior lesions, and we don't want to do this. So when I have something like this, the featureless breast. I'm sure I have edema, which is making me not see properly. What can I do when I'm working to overcome this problem? Anyone has any idea? Very easy. Doppler not this time. Something else. Excuse me? Next step, yes. What are we going to do? So I'm working now. I'm in my ultrasound room, and I know I'm doing my ultrasound, and I know that I have edema already from the features of the breast. It's featureless. I can't see my skin well, and I know I have edema, and I'm really worried that I might be missing something at the posterior part of my breast. So what do you think we can do? Yes, very good. So instead of using, we use our linear probe. Our linear probe are superficial probes. If you've been working breast, you know what I'm speaking about. It's a superficial probe. So we see only the upper parts of the breast. So when we have a deep lesion and we want to look at deeper lesions, it's like we're looking at the abdomen. When we do abdomen, because this is a deeper structure, we use the convex probe. So we use it also in the breast. And not a lot of doctors are oriented with this idea. They think that the deep probe is only for abdomen and deep structures, but this is not right. When we have a breast which we cannot see, we just very simply shift from a linear probe to a deep probe, and this will make us see much, much better and see the posterior parts of the breast. So this edema pattern, why did I concentrate on it and discuss it a lot? Because once again, it is what we see with inflammatory breast cancer, and we see with the other causes of other benign causes of edema in the breast and skin thickening, skin retraction. They are all in the same package. Like congestive heart disease and irradiated patients, this is normally what we would be seeing. And now to a very important tool in the associated features, which is vascularity. And as I said, I would never do ultrasound without making sure that my Doppler is okay and that it's working, because it completely changes my management and changes my scoring to this lesion. So we have lesions with absent vascularity. So are we confident that the lesion is not malignant once we don't have any flow inside? Are you confident, a radiologist? No, yes, definitely no. Okay, so it's a good positive. When we find it, I'm sure we have something solid, and I'm sure that maybe it's something to worry about. But when we don't have it, it's not good. A lot of lesions don't have it, but they are still malignant lesions. So they are good positives. When I find them, we're okay. When they're absent, I can't depend on this tool at all. And this is what internal vascularity looks like, and it's commonly seen with malignant lesions. And we have rim vascularity at the periphery of lesions are common with inflamed cysts. We can see the vessels. The vessels haven't entered the mass, and they're only seen at the periphery of the mass, and we call this rim vascularity. Now we have special cases with ultrasound. We just look at them, we know what they are, and we diagnose. And the most common of which is the different types of cysts. We have the simple cyst, very, very easy to diagnose. As we said, it's completely anechoic. We don't have any internal echoes within this black lesion here. We have shadowing, we have posterior enhancement, and we just see it and we just diagnose. It's a simple cyst, and it's a BIRAD 2 lesion. We have a clusters of microcysts, and it's really a benign finding, but at the end of the day, these small clusters, which are these small cysts which are gathered together in a small area, they can somewhat give me an impression that this is a microlobulated lesion. So I just have to look properly and make sure, is this a solid lesion or they are just small cysts, and the margin of the lesion appears sort of microlobulated because these cysts are packed together in a very small area. You need to make sure, because clusters of microcysts is just a benign finding. It's common in the spectrum of fibrocystic changes of the breast, but a microlobulated lesion is something very different. Once again, the BIRAD score is going to be different, and our recommendation for this lesion is going to be a biopsy. And we have complicated cysts. And what is a complicated cyst? It's simply an infected cyst. We have internal echoes. We have internal echoes inside this cyst, and these echoes hinder the transmission of the sound waves. So this time, in this type of cyst, we don't see the posterior enhancement, which we appreciate well on the simple anechoic cyst. we don't have transmission. But an important thing is, once again, we don't have Doppler in these complicated cysts, so we're sure that we don't have solid masses. It goes for follow-up, and we never biopsy complicated cysts. We're sure we're fine with it. It's not suspicious at all. Yes, of course. Never blood flow in a complicated cyst, because what's in the cyst and what's causing our internal echogenicity, it's just the infection. It's just debris. So we don't have flow. We never have flow. And as I said, it's very important in differentiating if it's serious or not, and differentiating complicated from complex, solid, and cystic cysts. Other special cases for mass in the skin, foreign body implants, and I can't be speaking about implants today. We don't have enough time, and lymph nodes. So we're going to stop and speak about lymph nodes, ultrasound assessment of lymph nodes, because in fact it's very, very, very important. The lymph node affection in breast cancer is something mandatory to do and see. It affects prognosis, and we're going to go into details in this. So to ultrasound assessment of lymph nodes. It's very, very important. We said very, very important, of utmost important, that any patient who has a lesion in her breast just have to go to the axilla and look at her lymph nodes. And ultrasound is a perfect tool to do this. It can detect anything, because the larger the lymph node burden and the more levels involved in a patient with a breast cancer, the prognosis is much, much worse, and the management is completely different. Do we have surgeons here? Oh, surgeons. Okay, great. So surgeons know very well that not all levels are operated upon, only level 1 and 2, right? Correct me if I'm right. 3 is not operated upon. So it's important when we as radiologists do our imaging and do our reports, that we have to comment on the things that our surgeons would be expecting us to tell them, and that would completely change the management of patients. So the normal structure of a lymph node, it's a kidney-shaped or reniform structure. And we have the afferent vessels, the axillary veins going in through the hilum of the lymph node, as we see here. So what about the afferents? The afferents of the lymph nodes come in through the cortex, not through the hilum as would be expected. They come in through the cortex. So this is the normal sonographic appearance. We see this black area outside here. This is the cortex. It should be thin like we see it here, and this part, the white part of this is the hilum of the lymph node, and it should be fatty. Well, what I mean by fatty is that it's white and the cortex is hypoechoic or dark, and it's the black part out here. And we usually measure the thickness of the cortex on our scans. It's very important, and we'll go through this. And I just want to make it clear that when we assess lymph nodes, we have to assess these lymph nodes in the longitudinal plane, not in the short axis plane, because when we look at the short axis plane, it gives us a false impression of increased cortical thickness. This is an important sign in ultrasound, and it's the first thing to happen in an affected lymph node. So once again, if you're going to measure the cortical thickness, which we do all the time, we have to measure it in the long axis. You measure it here from the periphery of the lymph node to the hilum, and we don't do it on the short axis view, because the short axis view will definitely give us a positive result. So let's talk about the progressive affection of lymph nodes. What happens first is that there is increased cortical thickness. So why there is increased cortical thickness, and why is this the first time we see an affected lymph node? It's because, as I said, the afferents which are carrying the malignant cells are going in at the periphery and not going in at the periphery of lymph nodes. They are going in here and not going in through the hilum. Okay, so they first thing where the malignant cells will settle down is in the cortex, and then they start to increase, and they increase the cortical thickness. So here we get a cortical thickness of 4 millimeter, and the upper limit for us is 3 millimeters. We can go down to 2.5 millimeter if we have a malignant lesion in the breast. And in fact, this is the kind of lymph nodes that we, as breast radiologists, should detect, because the more advanced stage of lymph node affection, like these nodes here, where we have completely lost our hilum, and we've completely lost our reniform shape, our kidney-shaped lymph nodes. We have now round, featureless, hypoechoic structures. These are the lymph nodes which are actually felt by our surgeons. They just know they are there. They send to us and tell and they say that we have fixed lymph nodes, so they know what's there. But those with the cortical thickness, these are the early affected lymph nodes, and surgeons don't know that these are affected. It's our role in breast imaging to tell them about this, and it helps in the early detection of lymph nodes. As I said, it's the first sign. It's the first sign of affection. And in the more advanced stage, of course, we lose our hilum. We no longer have our fatty hilum that we can see here. It's lost and it's rounded, and it's a highly affected lymph node. And these are the spectrum of various affections of lymph nodes with breast cancer. The type 1 and type 2 are normal lymph nodes. We can see the hilum, and look how thin the cortex is this time. It's very healthy, and we don't have a problem with it. It wouldn't exceed 1 millimeter. And we can have slightly thickened cortex, but our hilum is still present. And as I said, our cutoff for cortical thickness is 3 millimeter down to 2.5 millimeter if we have cancer in lymph nodes. Type 3 lymph nodes, or type 3 of the spectrum of affection of lymph nodes with the disease, is a diffuse hypoechoic cortex more than 3 millimeter. This is the first sign we get. It's the earliest sign of affection of lymph nodes. But we still have the hilum present. It's here. It's this fatty part of the white part here in the lymph node. Later on, we get a lobulated cortex, lobulated hypoechoic cortex, as we see here. Once again, our hilum is still in. And this is type 4 affection of lymph nodes. Type 5, we have focal hypoechoic cortical lobulation, and our hilum is displaced. It's starting to thin out now. We can't see this white preserved hilum we see in this image. This time it's thinning out, and it's going towards the periphery, so we call it a displaced hilum. And this is type 5 affected lymph node. And finally, type 6, which just a hypoechoic lymph node. We don't have a hilum at all. Maybe we can have some peripheral blood flow instead of the central hilar flow we see with the lymph node. And this is type 6 affected lymph node. And these are some abnormal morphologies. Once again, a type 3 lymph node, diffuse increase in cortical thickness. It's 4 millimeter when we accept 3 millimeter only. Here is a lobulated cortex, so we lobulated cortex, but the hilum is preserved, so we have a type 4 lymph node. This one is a lymph node with a hypoechoic cortex. We see the hilum displaced to the periphery. It's still there. It's still there. The lymph node is still not rounded, but it's displaced, and we have a type 5 lymph node. And finally, as we said, a hypoechoic mass. We don't have a hilum. We don't see anything inside here. We don't have a hilum at all. It's lost its globular or kidney shape or reniform shape, and now it appears globular. So this, of course, is a malignant lymph node. Can anyone notice something eye-catching in this image? No? Yes? Where is the, you can see a man? I can't. No, I can't see a man. There's something eye-catching in this image. So, yes. Okay. Excuse me? The other lymph node? Yeah, what about it? What do you think is happening with the other lymph node? There's definitely another lymph node on the image. What do you think is happening to the other lymph node now? Excuse me? Hypertrophic? Okay, we'll get to speak about the size. The size is, on the following slide, we'll speak about this, but it's not large. Anyone else wants to comment? Okay, so there is a, okay, yeah. Excuse? You want to know? Okay. So there is a lymph node actually there, but there's nothing happening with it. It's a completely normal lymph node. It's exactly like the one we saw in the first image. We have a thin hilum, the black part of the lymph node here. We have the fatty hilum. So what's eye-catching in this image is that this is what happens with malignancy. We have a completely affected lymph node, a type 6 lymph node, and the adjacent lymph node is normal, which we don't see except in malignancy. if we had an inflammatory cause for these enlarged lymph nodes, we would see a symmetrical affection of lymph nodes. All lymph nodes in the axilla with malignancy. We can have a type 6 affected lymph node, as we see here, and neighboring it is a completely normal lymph node. Okay? Now let's speak about nodal evaluation, and our dear surgeon here said that size is something we can look at. In fact, size it's not an important criteria, and we can see a very large lymph nodes. It's not important. We look at the hilum at the end of the day. It's on the contrary, a large lymph node can be a highly reactive lymph node, and we can see this fatty hilum filling the lymph node. Okay, we have a very thin cortex. Despite the size of the lymph node, we can see here, this is the cortex, the thin line around the fatty hilum. It's even thinner than other smaller lymph nodes. So size is not a criteria that we worry about when assessing lymph nodes. And we just get so many reports, and I see it a lot in my patients, and I would just look at the reports, and then I would see in the comment on lymph nodes that we have sizable lymph nodes, their size is whatever, it's written, and they're not commenting on the cortical thickness. So this is not right. The most important criteria to comment on is the thickness and the morphology of the node. As I said, the early affection of lymph nodes is seen through the cortical thickness, and all our reports, we report the cortical thickness does not exceed 3, the cortical thickness is 4. We have to comment actually on the exact thickness we see, because this is something which is going to change with neoadjuvant chemotherapy. And you know, neoadjuvant chemotherapy is chemotherapy given to patients before surgery. So nowadays, not all patients not all patients diagnosed with breast cancer go to surgery. No, we have something called chemotherapy before surgery. And this chemotherapy before surgery is neoadjuvant chemotherapy. So when we want to assess the response to chemotherapy, to this chemotherapy, we look at the mass, of course, and the size of the mass and what has happened to the mass, but we also assess the axilla, and we look at the pre-neoadjuvant reports and see what's the thickness written. If a lymph node, say, has 5 millimeter cortical thickness, 6 millimeter, we see really advanced numbers, and the cortical thickness can reach more than 1 centimeter. So we see the response of neoadjuvant chemotherapy through this cortical thickness of the lymph node. And we see very good results. So we can see a lymph node with 1 centimeter cortical thickness. It can be 3 or even less than 3 after her first dose or second dose of neoadjuvant chemotherapy. So as I said, it's a way to assess the response to neoadjuvant chemotherapy, and all our reports should include the cortical thickness of affected lymph nodes and should not actually include the size. Now to other findings in nodal evaluation, we see, as we said, cortical hypoepitogenicity. We can see in the advanced stage a loss of the fatty hilum, and the lymph node has become rounded or irregular in shape, and we don't see the central hilar blood flow. We said the blood vessels go in from the hilum or the center of the lymph node. When the malignant cells increase in the lymph node, they replace the hilum completely, and we start to have vessels at the periphery of the lymph node, not the normal central hilar flow we usually see. Now, what can ultrasound do regarding lymph nodes? It detects the sign of very early affection of lymph nodes, which is, as we said, increased cortical thickness more than 3 millimeters. It has another great advantage, which is the assessment of all regional nodal basins related to breast cancer patients. The axillary lymph nodes can detect the internal mammary, supraclavicular lymph nodes, and we are going to see images for this. And as we said, when we report internal mammary or supraclavicular or even level 3 lymph nodes, it makes a great difference to surgeons, because they cannot operate on these lymph nodes, and management is changed. And of course, ultrasound is the most excellent tool for doing intervention procedures on lymph nodes. Best way of guidance, best way to do any sort of intervention we do with our lymph nodes. So we said that that ultrasound can detect all different nodal basins. So what are these nodal basins? These are level 1, 2, 3 axillary lymph nodes, and our landmark for levels of lymph nodes are, which Dr. Surgeon will tell us. We have a landmark to determine. We determine, depending on it, the levels of lymph nodes, whether it's a level 1, a level 2, or a level 3 lymph node. So this landmark is Which thing is the landmark in the breast? Radiologist. Our radiologist can tell us what is the landmark in the landmark. Okay, I'll say it. The landmark for determining the levels of the axillary lymph node is the pectoralis minor muscle, not the major. Okay, it's the minor muscle. Minor muscle. Okay, so we say level 1, 2, 3. Level 1, as we see here in this image, level 1 is medial to the pectoralis minor muscle. Level 2 is deep to the pectoralis minor muscle, and it also includes the interpectoral muscle, interpectoral lymph node. This is a level 2 lymph node. And level 3 is medial to the pectoralis minor muscle, and this was the group that was called infraclavicular lymph nodes before. And we used to classify these lymph nodes previously into groups, into apical central groups. We don't use these terms at all now. We use levels of lymph nodes. We report lymph nodes as levels on our report, and this is what surgeons assess lymph nodes by. So we're all speaking the same language now. We say level 1, 2, or we say level 3. We say internal memory and supraclavicular lymph nodes. So let's see how they look on ultrasound. Okay. So we have here the pectoralis major, which is on the upper part of the image, and down here is the pectoralis minor. And since we said our landmark is the pectoralis minor, so this group A here, what would you expect this group to be? Where is it, group A? Excuse me? I can't hear. Behind the pectoralis minor. Okay, A is behind the pectoralis minor. Well, this is the pectoralis minor, and this is the A group lymph node. So I don't think it's behind it. Anyone else suggest something else? It's lateral to it because we're on the right breast, okay? So can you imagine that we are scanning now on the right breast, and this is the pectoralis minor. So we are on the lateral side of the breast here, the outer side of the breast. So this is our pec minor, this is our pec minor, and this is a large affected lymph node lateral to the pectoralis minor. So this is definitely a level 1 lymph node. Now this image, still again, we can see our pectoralis major and our pectoralis minor, and we have lymph nodes beneath the pectoralis minor. I said it, so this is a level 2 lymph node. And finally, this is our pec minor again, and it's finished. We're on the medial side of the breast now, and so this is level 3 lymph node. And as you see, it's very, very, very easily assessed on ultrasound. All these 3 levels, we can see them very, very easily because it's at the upper part of the breast, and we don't actually have a lot of breast tissue. And we can clearly identify the muscles as we can see them here, and we can clearly decide which level of lymph node is affected. And here we have a lymph node. Once again, I'm going to ask you, this is the pectoralis major. And why is it white, not like on the other images? Because with older age, muscles can get infiltrated with fat, and when they have fat, they appear whiter, more whiter than on non-fat scans. And here it is our minor. So what do you think about this lymph node? Where is it? Excuse me? Supraclavicular? Supraclavicular? No, this is not supraclavicular. It's here. Everything is here. So where is it? Excuse me? It, okay, so it's between the major and minor, right? Right, yeah, yeah. This is the pec major, the pectoralis major up here, the fatty one, the fatty replaced one, and down here is the pectoralis minor, right? These are the fibers of the pectoral. So we have a lymph node between both the major and the minor. Anyone knows its name? Has a special characteristic name. Have you heard about it before? Excuse me? I can't. Sentinel apical lymph node. Okay. Excuse me? Infraclavicular? No. Okay, so it's the Rotter's node. If you've heard this before, it's the Rotter's node. Okay. It's a level, it's considered a level 2. As we said, level 2 lymph nodes are beneath level 2 lymph nodes. Level 2 lymph nodes are beneath the pec minor, okay? But also it can include lymph nodes if they are present between the major and the minor. They have a characteristic name, it's Rotter's node. They're actually not seen that common at all, but this was a case where we detected this lymph node and they're actually operated upon. So we don't do assessment of all levels on a routine examination of ultrasound. If I have a patient who I'm doing a routine scan, I definitely won't go to do all these levels of internal memory. What we do in assessment of our lymph nodes, we do sort of a stepwise fashion. So if I have a patient with breast cancer and I do level 1 lymph nodes, I just go lateral to my pec minor and I find affected lymph nodes, then I'll go and search for my level 2 lymph nodes. If these are affected, I will go and search for my level 3 lymph nodes. But we don't do it in our usual examinations. We just stick to level 1. We take a look at level 1, those lateral to the axilla, and see if we have anything affected there or not. If it's normal, we can't see. Yes, we see. Yes, we see. We see lymph nodes all the time. Normal lymph nodes, like we described earlier in this assessment of lymph nodes, the ones with the preserved hilum, the thin cortex, we see them all the time. So don't expect that there will be a lymph node in the axilla which we cannot see with ultrasound. This will never happen. It's an excellent tool, as I said. The axilla is superficial, lymph nodes are superficial. It's very, very easily assessed, very, very easily seen, and we see them all the time. We can have breast cancer patients actually who have normal-looking axillary lymph nodes, those with the thin cortex, the preserved hilum, no problem at all. And we actually comment that we don't have suspicious-looking lymph nodes. But once they're there, and we're seeing them for sure, no problem with that at all. Okay, and we can also see, as I said, internal memory lymph nodes, and this is a very, very important decision. And when we report this to our oncologists, they are actually very happy with us because this changes the management completely, and it also changes the radiation field that they're going to put the patient in. Once we report the internal memory, this is a complete change of management. And actually, once again, as I said, with all lymph nodes with ultrasound, it's something very easy to see. Here we have costal culture. We just go on the medial side, parasternally on the medial side of the breast, and we have our costal cartilage here, and this is the other costal cartilage, and between them we can see a small soft tissue shadow of an affected lymph node, because normally we don't see internal memory lymph nodes except if they have pathology in them, even if their size is small. And up here, we will see our supraclav lymph nodes. We see them a lot, and unfortunately, it's kind of a really advanced disease in patients. And as we see here, it's a rounded hypoechoic structure, definitely affected. And these are kinds of lymph nodes which we don't see normally and are not there normally. They don't enlarge and they don't appear except if they are actually affected by lymph nodes. Once again, when we report these high-level lymph nodes, whether level 3 axillary lymph nodes or internal memory supraclav, surgeons know that they do not operate on this high level of nodal affection or high level of nodal burden, and they have to change the management and their surgical strategy towards this patient. So what do we call regional disease and what do we call metastatic disease regarding axillary lymph node affection in patients with breast cancer? Regional lymph nodes are considered level 1, 2, 3 axillary lymph nodes, and very surprisingly that ipsilateral internal memory lymph nodes or supraclavicular lymph nodes are also considered regional disease. They are not metastatic at all. So if we have a patient with supraclav, this is not a metastatic patient. It's a regional disease affection or regional nodal affection. But metastatic disease is considered as ipsilateral, as the same side, it's the same side of the malignancy if we have cervical and any lymph node on the contralateral side, which is a bit controversial because sometimes we can feel that if it's the other axilla is affected, this is not metastatic, but actually if we have contralateral lymph node on the other side, this is metastatic disease. It shifts our patients from local disease in our T&M staging, and now we are in the M1 stage where we have metastasis in the contralateral side. Actually, we see it a lot. And once again, why is it important to classify nodes into these three levels? As I said, surgeons will perform on level 1 and 2, and they will not proceed on level 3 or higher levels of lymph nodes. So reporting this will completely change management. And ultrasound is perfect for doing ultrasound guided interventions, whether fine needle aspiration cytology. In fact, now we do core biopsy. We'll be speaking interventional breast procedures in detail at a further part of this lecture. It's just excellent. So as I said, ultrasound is the place for assessment of lymph nodes in patients with breast cancer, and there's no better tool, in my opinion. There's no better tool, and this is actually documented in the research and in textbooks that ultrasound is the best tool to assess lymph nodes in breast cancer patients. Now, back to our practical approach. We finished discussing the different descriptors of breast lesions that we can see on mammography and we can see on ultrasound. So we finished this part regarding mammography and regarding ultrasound. Now we have to determine the BI-RADS assessment category and recommendation. And as I said, we have to think about all the lesion as a whole and not as a single descriptor, and we decide what BI-RADS we want to put to this lesion overall, not to just one specific descriptor. So what is the BI-RADS? What is the BI-RADS? We want to speak about BI-RADS. BI-RADS is a number score. Okay, it's a number score from 0 to 6, and we are mandated to put it on all our reports. So we put it according to the findings we see. So we're going to go through from 0 to 6. So when we put a BI-RADS 0 on our report, it means that this report is incomplete and that we need to do a further investigation. And this is actually very common in Western countries, because they do a lot of screening mammogram and they don't go for ultrasound with screening patients. Where we come from, or in Egypt, in Cairo, in my hospital, we do screening ultrasound for every patient who is coming to do a screening mammogram, except for the fatty breast, which we are sure that we don't have lesions in. These may not go for ultrasound, but otherwise we do ultrasound all the time. So we don't usually use BI-RADS 0. We don't commonly use it. We finish the examination. The patient is coming for her screening mammogram, and at the same time, we'll do the screening ultrasound, which manages to detect a lot of things that cannot be seen on the mammogram, as we said, because of her breast density or whatever reason. So 0 is not something we usually use a lot. And BI-RADS 1, what is a BI-RADS 1 lesion? It's a negative breast examination. Okay, so we did the scan and we don't have anything to report about at all. So this is a negative scan, and we put BI-RADS 1. 2 we put it when we have benign findings. 100% sure it's a benign findings, and like what we can put in this category. The most common example that we put in this category, fibroadenosis. Adenosis. What else? Anyone has any idea? Yes, this. Anything else you'd like to put in this BI-RADS 2 category? Anyone has any idea? Okay, so the most common lesion put in this BI-RADS 2 category regarding ultrasound of the breast is simple cyst, because we have several types of cysts, as we said. It's not only one type. So the simple anechoic cyst is the cyst which we put here. And as we put it, and once we put a BI-RADS 2 on this report, then it means that we are 100% sure that we don't have any problems, we don't suspect anything, and we're safe and we're in the benign category. I just like to comment on fibroadenosis. Fibroadenosis, it's one of the most commonly written findings in regarding breast, and actually we've stopped using it a lot of time ago, because it's a pathological diagnosis. When we say fibroadenosis, it's not for us radiologists to say that this is fibroadenosis. At the end, adenosis is a pathological finding, so we leave it for our pathologists to relate to this finding. It's not a radiological term at all, but it happens all the time that a patient may come in and say, I have pain in my breast. So all females have pain in their breast. It's not something unique to a certain disease. But we have imaging and we have descriptors and we have our tools. So if we don't find anything in these breasts, we simply comment that it's a negative study, or we have some cyst and it's a BIRADS 2 study. And we don't comment on the clinical problem. Okay, we know there's a clinical problem, but this is not of concern for us because there is nothing in the breast. Once again, as I said, we cannot report fibroadenosis on a radiology report. It's for pathology, in spite of it being the most commonly reported. I don't know what is wrong on a lot of reports I see. Now, probably benign. Let's go to the BIRADS 3 category, the probably benign category. So what would you like to put in a probably benign category? As very common lesions in the breast, very common. Fibroadenoma, great. So I want to ask something. When you have a fibroadenoma, would you like to put it in a BIRADS 2 category or a BIRADS 3 category? What do you think about this? Excuse me? No, this is adenosis. Now we're speaking, this was fibroadenosis. No, I'm speaking about a fibroadenoma now. I'm speaking about a fibroadenoma in the breast. Excuse me? What is the question? When a patient comes in and I diagnose a fibroadenoma very confidently, I'm pretty sure, I'm sure what it is. It's a fibroadenoma. So at the end of the report, I have to put a BIRADS category score by 2. Who would say 2? Who would say when you definitely see a fibroadenoma that you're not worried about, it's well circumscribed, we don't have more than 2 to 3 gentle lobulations, we're not worried? Who would say this would be a BIRADS 2 category? We would put it for the first time as a BIRADS 2 category. Please vote and just raise your hand. 2? Doctor 2? Okay, so probably benign. Okay, so fibroadenomas, when we see them and we're pretty sure what's happening with this fibroadenoma. Is it going to remain stationary in size and sonographic appearance and mammographic appearance during these 6 months, or is it going to change? So after the first 6 months, the patient comes to us again and we assess the lesion. If it's the same, we don't have a problem, but we still can't write a BIRADS 2 except after another 6 months. And except after actually 1.5 years. She has to follow up her fibroadenoma, whatever benign looking it is. We have to follow a fibroadenoma, the first diagnosis of a fibroadenoma, for 2 years, and her follow-up goes on this schedule. We see her today. After 6 months, we see her again. After 6 months, we see her again, and then after a complete year. So this is the 2 years duration of follow-up for her fibroadenoma. If it's stable, if it's the same size, if it's the same density, it's the same shape, it's it's downgraded from a BIRADS 3 to a BIRADS 2 fibroadenoma, or a BIRADS 2 lesion. We tell the patient this is nothing to worry about. You can completely forget it as if it's not there. We don't need any further follow-up. And if it increases in size or its appearance is different now on her follow-up scans, it's not like before, an increase in size, but we have to say a reasonable increase in size, which is almost 25%. This is what's documented. If we have a fibroadenoma, in spite of it looking benign, and after 6 months we find a 25% increase in the size of fibroadenoma, it's converted from a BIRADS 3 lesion to a BIRADS 4 lesion, and we have to biopsy this lesion. Yes.
But the problem is usually
Yes.
doesn't do the
Yes, we're lost, definitely.
at the same radiologist.
Yes.
From radiologist comparing with another radiologist, maybe there is some.
Yes, yes. So we have huge problems in follow-up. I completely agree. We can lose the patients for follow-up. At least they don't want to follow up. I tell my patient, you have to come and I have to see you in 6 months, and she just decides against that and doesn't go, and she doesn't go. It's okay if she wants to go to someone else. we should all be agreeing on the terms we have. And as I said, ACR and BIRADS are for standardization of reports. We should all speak the same language. We should all know that a fibroadenoma is never put in as a BIRADS 2 from the start. Yes, of course. This is our problem. I always say we see what we know. This is the truth. So if you see you know something, you do what you know, and you see actually what you know. If you don't know it, you will never see it, and you won't follow the rules. And a lot of reports I get, very, very unfortunately, I see no BIRAT score on the reports, which is something not accepted. Actually, from 1989 in the States, it's by federal law that no breast imaging report should go out without a BIRAT score. And it's not actually we doctors only who know this. I had a patient once, and she had a mammography in a really well reputed and a well-known hospital, large hospital in Egypt. And then she said, I want to repeat my mammography. So regarding radiation dose, I told her, we can't repeat in 1 week. Why do you want to do this? So she told me, because I don't have a BIRAT score on it. So a lot of patients now are aware that we have to put our score, and no breast report is efficient and good without a BIRAT score. And as I said, if I just get a report without a BIRAT, whether it's an ultrasound, whether an MRI, whether mammography, I just look down there and I don't see my score. I just completely ignore the report, and I know that who's doing this report doesn't know the BIRATs. And as I said, in the States, it's by federal law, and it's not accepted that any report can go out without having a BIRAT. And it's very important too, because it's going to guide our management. It's going to tell our surgeons at the level of suspicion. We just can't communicate like that. When I put a score, when I say I put to 1 or 2, then he knows we don't have anything to worry about. If I put 4 and 5, we have more suspicious lesions, as we can see, as we're going to see here now. Okay, so BIRAT 3, as we said, the most common thing which is put in the BIRAT 3 is fibroadenoma, the first diagnosis of fibroadenoma, and we'll follow her up for 3 years, hopefully. Hopefully she'll have her kids and she'll do her follow-up. And a lot of patients can opt for a biopsy. They don't want to go through a 2-year follow-up. When you tell a patient, okay, we're going to follow you up, but we want to see you in 6 months and 6 months. So she says, no, I either remove my lesion and just get rid of it, yes, and put my mind to rest, or I can take a biopsy to just make sure it's a fibroadenoma and not go through the lengthy follow-up. She knows she's not up to it, and that is going to take a lot of time, and she chooses to do a biopsy. And once it's we get a pathology of this being a benign fibroadenoma, it's converted to BIRAT 2, and we're not worried about it at all. Well, surgeons can tell us about that. They tend to remove the mass, but I think when it's usually big. I think they remove the mass when do you remove fibroadenomas? Surgeon can tell us. Anytime? Hard question.
When I don't remove it.
Okay. Okay.
When I don't remove it.
You don't remove it?
No. When the question should be the other way.
Oh, when don't you remove it? Okay. So when don't you remove it? Yeah, right. Yeah, okay. So most of the time, yes, surgeons can remove. Yes. Yes, yes, of course. Yes.
Rotation in the breast.
Yes.
Accessibility for surgery.
Yes, yes.
All these are parameters.
Yes.
1 year old.
No.
With a small.
Yes,
Do I need
yes.
to go?
Yes, yes. But usually large fibroadenomas, large. Yes.
Keloid is too much.
No,
So when I don't
something.
go,
Yes, most of the time you go.
keloid is
So cosmetically, it's not good.
to be disfigurement. To be right also. Right. This as such can be one of the pre-malignant things.
Yes.
The keloid.
Yes, yes,
That
definitely,
can be.
definitely. So size
Size
is a very
considerable.
that is considered all the time. So we have a general rule which states anything less than 5. Yes, but it's actually it's big. Because it's big already, the patient is not happy with a big fibroadenoma, anything around 2.5. Yes. All breast cases go to gynecology. All breast cases go to gynecology because we have the. follow up. We don't send her to the surgeon, which we should send it to the surgeon. No, and most of female patients now, when they have problems in their breast, they definitely go to the gynecologist because they feel that breast is gynecology. So breast is not gynecology, breast is surgery. But most of the time,
Some of the like in Germany,
yes,
the part of the gynecology.
yes, yes.
Only,
Only Germany is gynecology.
gynecology. Only in Germany.
Okay.
So some populations they have either kind of belief
Mindset, their mindset, yes.
with anywhere live somewhere else before. They have some.
Yes, it's mindset because patients feel that if we go for a surgeon, then we're going to have surgery, which is not right. And I tell my patients this all the time. He's the one who's concerned with this lesion or the breast lesions, but it does not mean surgery. They feel that once we go to meet a surgeon, then we're definitely going for operation. And a lot of our patients don't want to go for operation. But again, as I said, size is a very important
Which is one
criteria.
of the good important things because they are sleepy.
Yes, yes,
They just want to complete themselves like I have done.
yes, yes.
They know they have to go at the end of the day
To the surgeon, yeah.
but they just
Uh,
want to wash their
yes,
mind
yes,
and divert to the other thing.
yes, yes. So this is actually right.
يعني تذاكي في بعض الأحيان.
No.
تذاكي يذاكون.
Yes, yes,
يتذاكون.
yes.
يعني
I usually advise. Sorry to my gynecologist, but I usually advise my patients to go to a breast surgeon because this is their specialty. And we'll speak about some cases going to the gynecologist here now in a few while. Size is again, I want to say that size is a very important criteria, and we have a general rule, which is anything less than 5 millimeter is usually benign, and anything more than 5 millimeter we'll definitely look into. So a lesion which is 2 or 3 centimeters, I don't think it will be left in the breast. The patient is already not comfortable about it. She actually has a ball in her breast, and most of the large lesions are its size. But the problem is with fibroadenomas, they recur. Yes, yes, recurrence is very high with fibroadenoma, so this is actually a problem. Anyhow, at the end,
I believe fibroadenomas develop at the age of
yes, yes,
I believe.
yes, it's true.
At start to develop when the girl converted to a young.
Yes, yes, this is true.
This is the time of the appearance of the
Yes.
fibroadenoma, the very micro, smaller size.
Yes, yes,
Then
yes,
it will grow up. That's why they discovered by 16.
yes,
20,
yes,
when it has reached 2, 3, and 2.5 years.
yes, yes,
But basically, it developed when
Yes.
the hormones start to change.
yes, of course. This is actually true, and it's a very important factor in assessment of fibroadenomas. Fibroadenomas are developed when breasts are developing. This is true. So when a 40-year-old comes in and says, "I have a lump," okay, I do my ultrasound, and then it looks like a fibroadenoma. It's well defined. I don't have problems with it. But why does she fear a fibroadenoma at the age of 40? So definitely this lesion has increased in size. She hasn't felt it before. She hasn't complained about it before. We have a lesion which has increased in size, which was not palpable over the 40 years, as we said, if it's a fibroadenoma. So it's normally developing in the younger age when the breast starts to develop. And now she's complaining of a fibroadenoma at the age of 40. So this lesion has definitely increased in size. And as I said before, any lesion which has changed, which has become palpable after it was not palpable, which has been increased in size and the patient is now complaining of, we just have to go for biopsy. Any change, we cannot ignore it, and we have to do a biopsy to make sure that we are safe. Whether this biopsy is surgical biopsy, is surgical excision of the lesion and sending the whole lesion to the pathology, or a core biopsy. No, 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 it doesn't develop, it does not change, it does not change into carcinoma, but the problem is we have high-grade tumors. It does not change, no, no, no. So if I get a pathological diagnosis of fibroadenoma, is this going to change? No, it does not change. We have a category just like fibroadenomas, we'll speak about it soon. It's like fibroadenomas, it's not fibroadenoma, it's phylloid tumor. This is something else. I'll talk about its different categories now, but I'm speaking about a fibroadenoma. This does not change. The problem is, also you can see a lot of patients coming in and saying, the doctor told me it's a benign lesion. I've left it for so many years and now it's malignant. No, it's not malignant. She developed a new malignancy. Now she developed a new malignancy because both are very, very common. Fibroadenomas are common and breast cancer is very, very common. It's 1 out of 8 ladies, as I said, every 8 ladies. Could you believe it that every 8 ladies, one of these ladies is going to get breast cancer during her lifetime? So both are very common lesions. And the true fact or the true thing that was happening, she had her fibroadenoma for years. No cancer will stay the same for years, of course. And now she has developed her fibroadenoma. I mean, she had her fibroadenoma for years. But now she has developed a breast cancer. So it's her conception that she feels that her benign lesion, which she had for years, has now changed into a malignant lesion, which is not right. She has developed a new breast cancer. So we finished the BIRAD 3, and as we said, most common lesion written in the BIRAD 3 or taking a BIRAD 3 category, fibroadenoma. No. Fibroadenoma, does not change. It does not change. It does not. Excuse me? Yes. When a patient tells you, I've had my fibroadenoma for years, the doctor told me it's benign, and now this has converted into a malignant lesion. No, it has not converted into a malignant lesion. She has developed a malignant lesion, which is no relation at all. Yes, she has developed a new mass, but in her mind, she feels that this mass is the fibroadenoma that she had for years, which has converted, and that she was told it's something benign and you don't have to worry about. So this is the problem. Another problem with fibroadenomas is that some high-grade tumors, and we'll see some examples, can look like fibroadenomas. This is the major problem we're having now. Yes. Unless the diagnosis was wrong before. But definitely speaking, if a lady has breast cancer, she will never stay for years with a breast cancer without it manifesting. So there's nothing like I had a benign lesion for 20 years. This will never happen. A malignant lesion within months will find different findings, and it will be palpable, will get lymph nodes. No breast cancer will stay in the breast for such a long time. Now, as I said, we put fibroadenoma in the BIRAD category 3. And another disease which is very common, which we put in this category, is the fibrocystic disease or fibrocystic changes of the breast. And our gynecologists know it's related to the postmenopausal, perimenopausal period, hormonal disturbance after 40. Perimenopausal age are hormonal imbalance. Ladies have hormonal imbalance. So most of the time they start to develop cysts, and it's so frequent. We see it almost every day. We have to see a patient with fibrocystic disease. This is true. So they've changed this name now from fibrocystic disease to fibrocystic changes. It's an FCC, fibrocystic changes. Why? Because they said that it's just so common. It's in a lot of patients in the perimenopausal age. So we don't want to call it or term it a disease now. We say that it's just changes. But we follow up these patients because a lot of them have complicated cysts. Yes, new lesions. These patients have cysts, and they have different categorizations. They may have simple cysts, they have complicated cysts, but they don't have complex cystic solid cysts. Because this, as we said, is something serious, but they range between the cyst and the anechoic simple cyst and the complicated cyst. And complicated cysts actually are put in the category of the BIRAD 3. We also want to follow them up and see if they increase in size, and we have to remove them. So when we have fibrocystic changes with different stages or different kinds of cysts, they are put in the BIRAD 3 category. So once again, BIRAD 3, fibroadenoma, complicated fibroadenoma first diagnosis until 2 years, when we will convert it to a BIRAD 2 category. Complicated cysts, fibrocystic changes, these are all the things that we put in this category. Now let's come to a very important BIRAD 4. BIRAD 4, and I think this is the most important decision we want to make, like the debate we went through now. Do we want to take a biopsy from this lesion, whether a surgical biopsy, which means, what does a surgical biopsy mean? It means that our patient is going to the surgeon. She may have a big mass and it's already going to be removed. So there's no need to have a pre-operative biopsy before it. She's removing the lesion from her breast anyway. So when we remove the lesion, we send the whole lesion to pathology, and the pathology will tell us what this lesion is, okay? Or core biopsy. So the aim of our imaging and describing our lesions with the ACR, BIRAD, the lexicon, and all the descriptors we discussed now is to properly decide if we want to put a lesion in the BIRAD 4 category or we'll go for BIRAD 3. Okay? And in my opinion, this is the most important decision we have to take. Because if you put a malignant lesion or a serious lesion in BIRAD 3, then you're delaying this patient. If it turned out to be breast cancer, you're delaying this patient for at least 6 months without a definite diagnosis. And at the same time, we don't want to every lesion we suspect just go to BIRAD 4 because we're going to lead to unnecessary biopsies and too much biopsies. We don't want to do that. And any patient who is scheduled for a biopsy or we tell her you have to have a biopsy, she's worried all the time and she knows that there may be cancer. So we don't want to be asking for too much biopsies, unneeded biopsies. So at the end, our important role and our important categorization of breast lesions is to decide according to what we saw in our imaging if we're going to put these lesions as a BIRAD 3 lesion or a BIRAD 4 lesion. And by the textbook, it's written that we always should increase our index of suspicion. And once I suspect a lesion, once I see just one suspicious descriptor or something, no, I'm not comfortable about this lesion, I'll definitely go for a BIRAD 4 lesion and take a biopsy, make sure that we don't have malignancy within this lesion. And I won't put it for follow-up. We usually tend to go towards the benign. So when we're working, maybe the younger staff or less experienced staff will say, let's see her after 3 months. They feel that they don't want to make the patient worried. So they tell her, no, better go for follow-up. And this is not right. Once we suspect, we do a biopsy and then put a peace of mind to what is this lesion, whether it is benign or malignant lesion. So at the end of the day, I'm not going to put anything in a BIRAD 4. I'll just say that if any suspicious descriptor or feature is seen in this lesion, it goes to BIRAD 4, which equals biopsy, whether surgical biopsy, whether core biopsy, but we have to take tissue from this patient and do a tissue diagnosis and make sure that we don't have any malignant cells in them. Now to BIRAD 4 and BIRAD 5, I mean. BIRAD 5 is the textbook rule of textbook definition of malignancy, highly suggestive of malignancy. When we put a BIRAD 5 to a lesion, we should expect that it's around 100% malignant. So it's not very good for a radiologist to write BIRAD 5 and then coming back as a benign lesion. The pathology said it's benign. No, we leave it to the lesions that we're pretty sure that this is definitely a malignant lesion. With BIRAD 4, this is on the contrary. When I put a BIRAD 4 on my report, can come benign, can come malignant, no problem at all. It's not bad to put a BIRAD 4 and come benign, no problem at all. But when we have a classical appearance of malignancy and we put a BIRAD 4 score on the report, it should not come back from the pathology as a benign lesion. And finally, BIRAD 6 lesion, which is a known biopsy-proven cancer. So a patient may have breast cancer in her right or left side of the breast. She took a biopsy from it, and we know that we have cancer, but she hasn't done any surgery. She hasn't done chemotherapy yet. So why do they come? A lot of patients come because in some practice, they do mammography on one side only. We don't do this at all in my country. Yes, they do one side, which is not right at all. We should not do this. Have to do bilateral scans even to compare both breasts. But a lot of time I see mammography on one side, and the patient tells me I have a complaint on this side, and we don't need to do the other side, which is not good. Excuse me? How it comes? Yes, it just happens when you're in the field. I think you'll see these things. We do on side. So she has a pathological diagnosis of breast cancer on one side, and she hasn't even had a look on the other side. So this is when we put a BIRAD 6 on the lesion. Also, a lot of surgeons, as I said, the decision of the lymph nodes affects them greatly. So the surgeon can call me and say, we want to properly assess lymph nodes once again. We want to know the levels now that we have a pathological diagnosis of breast cancer. We want to see the levels. We want to assess the lymph nodes once again and see proper assessment of lymph nodes and the levels. And also for patients on neoadjuvant chemotherapy, we said that neoadjuvant chemotherapy is chemotherapy taken before surgery. It's taken before surgery, and the patient takes around 6 cycles of chemotherapy. We want to assess the response to this chemotherapy. Is the patient responding to the treatment, or is she taking the cytotoxic effects of the drug only and there is no response to treatment at all? And how do we do that? The patient starts her chemotherapy, and then she has her baseline study before her chemotherapy, and she comes to us. We compare both scans, her images before and after, and we see if there is a response which is seen as a decrease in size, as a decrease of her lymph node burden, and we report these findings on our report, and then we put a BI-RADS 6 category on her report. So these are our BI-RADS. We go from 0 to 6. We use it in all our imaging modalities, whether mammography alone, whether ultrasound, whether MRI. And we should not issue a breast report without BI-RADS. This is not right. And as I said, this will definitely say that this report is not the best thing. So for BI-RADS 1 and 2, what do we do? Nothing, because BI-RADS 1 and 2 says that the breasts don't have anything in them, nothing to do at all. For BI-RADS 3, we do a follow-up for 6 months, as we said. And BI-RADS 4 and 5 are the ones which we are concerned with, and these are the ones which will go for biopsy. Okay, I think we have a break, a prayer break now. And then we see some kids. Yes, we're coming to it, don't worry. Yes, we're coming to it. Yes. Okay, this one? Yes, okay. Okay. Thank you. Hello.
You forget the
Yes,
price
of
and
course.
like this.
thank you, and I hope you enjoyed your
Fine. Okay, our first case, we have a 46-year-old woman coming for her regular screening. So what do we see on her mammogram first? So we saw the diagnosis. We have a density here in the upper outer quadrant of the right breast. This dense lesion we see here. So we cannot clarify what this lesion is on mammography. We have to go to an ultrasound to check this lesion and see what the lesion is. And what do we see on the ultrasound? Okay, great. Yes, we see a cyst. So what are the descriptors of the cyst? It's completely anechoic. It's completely anechoic. We don't have any internal echoes inside it. We can see posterior acoustic enhancement behind. As we said, the fluid enhances the flow of the sound waves. So we get enhancement behind the cyst, and we don't have any flow. We put our color Doppler on to make sure that we don't have any small undetectable solid lesions or nodules within the mass. And it has a thin perceptible wall, so it's typical criteria of a simple breast cyst, and it takes a BI-RADS. So when we're going to report, then every lesion we'll speak about, we're going to speak about the BI-RADS category that we will put at the end of our report. So what do you think? Yes, definitely, it's definitely BI-RADS 2 descriptor or BI-RADS 2. No, I don't know what it is from the memo alone. We don't work by memo alone. No, no. Oh, yes, this is what I was speaking about the BI-RADS category D. Because everywhere, especially in Eastern countries, they do screening mammograms all the time, and they don't do a complementary ultrasound or a complementary screening mammogram for their patients. So a lot of times they are putting the BI-RADS category 0, which means that they want this patient to do a further evaluation, which is actually ultrasound. We already do a screening ultrasound with every patient, and this in this case it's a diagnostic ultrasound already because the patient has something on a screening mammogram. And we do it for all our patients. So usually the BI-RADS category 0, we don't use that much. We solve our problems with ultrasound. Yes, yes, I can't clarify what it is. So on mammography, as we see here, it's just a dense mass. mass? What is this mass? Do I know it's a cyst? Is it a solid mass? Is there flow inside the mass? These are things above the capability of mammogram and information the mammography cannot provide us with. So, of course, she has to go to an ultrasound. Once we see any finding on mammography, to clarify what this finding is, we have to go for an ultrasound. And as we said, it's a simple cyst. It's a BIRADS 2 score, anechoic, it's parallel. The long axis of the lesion is parallel to the surface of the skin. And cysts are very common, as we said, in perimenopausal and postmenopausal women, and more common if the patient is on hormone replacement therapy. And present in a lot of patients, we don't have any problem regarding them, and they are very, very safe. Now, case number 2, a 50-year-old female felt something in her left breast. So can you spot out the area of concern, or where is the lesion? So these are the initial views, and then we have magnified views here. So what do we have on the initial views? This patient is a patient who's coming with a palpable lump already, and she, not a lump, she feels that the feeling of her breast is not normal. Yes, very good. We have something at the lower quadrant of the left breast. This is the area of concern at the left breast, and we. Yes. So we see something. We see an area here which we don't like, of course. This is not good, and we want to further evaluate it. We magnify our images. Like I said, something we have to do with all mammography films. We should not look at a mammography film without magnifying, or without a magnifying glass in our magnifying lens in our hand, because we will miss a lot of suspicious microcalcifications, as we see here. Now that we've magnified our views, we can clearly see the suspicious microcalcifications. And then she goes to ultrasound. We see a mass, and I'm going to use this mass to go through the BIRADS descriptor and show you what we do in practical work. So the shape of this mass has to be an oval mass or a round mass, and if it's not oval or rounded mass, we're going for irregular. So would you prefer to put this mass in which category? Irregular. Everyone says irregular. Okay. I can choose oval. I agree it's not that oval, but if I put it in the irregular category from this image, then I'm going down the path of malignancy, and I'm still not sure if I want to go into this pathway or not. So we'll say oval, and we'll see what will happen on the rest of the images and assessment of the remaining BIRADS descriptors. Let's see. So the margins. What about the margins? So as we said in the BIRADS, we have circumscribed margins and non-circumscribed margins, and you have to choose from the if you choose non-circumscribed, you're going to choose, is it either indistinct, angular, microlobulated, or specular? Excuse me? So first of all, we're definitely not circumscribed, right? We're in the not circumscribed area, right? Because it's circumscribed in certain parts, here maybe, but others is not. And once any part of the lesion has a suspicious finding, so we go for the suspicious finding. So I agree that we are now in the non-circumscribed area. We have to choose between these four. It's either distinct or you choose angular or microlobulated.
I take microlobulated.
You take microlobulated. Anyone wants to take something different? Okay, we could think of microlobulated. This is some microlobulation here, but I would prefer angulated or angular lesion, because here I see some angles and it's a bit sharp around here, and here too I can see some sharp corners, so I would prefer angular. And now we're definitely walking into the malignant pathway. What about the orientation of this lesion? Excuse me? Not parallel? Not, no better there. So it's parallel. It's parallel because this is the long axis of the lesion, right? This is the long axis. So is this long axis parallel? No, the long axis, this is the long axis of the lesion. So is this axis parallel to the surface of the skin, or it's not parallel to the surface of the skin? What do you think? It's parallel, the long axis, right? Definitely parallel to the surface of the skin. This is the line of the long axis, this line I'm going through, and this is the skin up here. So is it parallel or anti-parallel? It's parallel, which is the only benign feature in this lesion till now, okay? Echo pattern, we have our descriptors and our option for echo pattern of lesions. Anechoic, we compare, as I said, to the surrounding fat. This fat, this grating here is the fat, so we compare this lesion to the fat and we decide, is it anechoic with no echoes inside, or do we have echoes inside? Is it hyperechoic? Is it higher than the fat beside it? Is it hypo? Is it less than the fat? Or is it exactly similar to the fat? So you would prefer, yes? Anyone prefers something else? No? So, okay, so it's here been the curses. This is the lesion, okay? This is the lesion. It's black, it's a black lesion, it's a dark lesion, and this is the fat. This is the fat. It's definitely not anechoic because I see internal echoes inside this lesion, so we're not in the anechoic stage at all. It's not hyperechoic because hyperechoic means that it's higher than this fat, and this echogenicity is definitely lower. It's not higher. Okay. As we said, it's definitely lower. This lesion is less than the surrounding fat, so it is a hypoechoic lesion. Yes, we said the fat is the reference point for us. Okay? Yes, yes. It's our reference point. So it's outside here. This is our reference point. It's outside here. It's gray. So fat should be dark gray on ultrasound. And you know you're doing a good ultrasound scan when you see it gray. You just play in your gain and you make sure that you see the fat gray. If you see it higher than that or not gray or brighter than that, then your parameters are not right. We see our fat because all breasts have fatty tissue. So we see our fats, we adjust our parameters, and we compare our lesions to the surrounding fat. So it's either when it's like it, it's hypo when it's less than this, it's echogenic when it's higher than that, or it's anechoic, no echoes at all. Okay? So I agree with there are some areas which we might feel there's a increased echogenicity, and we'll speak about them now. So what about the posterior features first? The posterior features are what we see behind the lesion in this area. Excuse me? Yes, we can say there is shadowing here in the periphery. Yes, yes, exactly. In the periphery of the lesion, this is shadowing. This is the dark area we see here. This is what we call shadowing. And we definitely see shadowing here related to the periphery of the lesion. And behind the lesion, we can see some sort of enhancement. It's not that outstanding like that. We're speaking about the posterior features. We'll say what the mass is. The posterior features, we have to choose from these. It's combined feature. We said we have shadowing. We said we have shadowing, like doctor said. We have shadowing at the periphery of the lesion, but in the center of the lesion, there's some sort of enhancement. Okay? Now to the... Yes. The lateral side, this area. Definitely. Definitely. Yes. Yes, yes. So it's the calcifications we've seen on the mammography, and fortunately now we do have a correlate on ultrasound. Previously, these calcifications or the microcalcifications we saw on mammography, the ones we described before and the ones we saw in this case, we didn't recognize that there was an ultrasound correlate to it. Now there is an ultrasound a lot of times, not all the times of course. There's an ultrasound correlate to it, and we call it non-mass lesions on ultrasound. If you've heard about non-mass enhancement in MRI, of course, we use this descriptor all the time in MRI and in our contrast studies. Now we find a correlate to these non-mass lesions on ultrasound. And we see it with calcifications, and it is this area, this linear, ill-defined area beside the mass. You can see a mass, but the non-mass lesion, and as I said, it's a new descriptor. It's going to go down in the new edition of the BIRAD. It's still not used, and We don't see it a lot. Not everyone uses this term, but it's going to go down in the new virus ACR lexicon that will go down recently. This is the lateral to the mass, and as I said, it's an ill-defined area, hypoechoic area. We see ducts in this area, and we can see the calcifications in this area. And we say that it is a non-mass lesion on ultrasound.
What do you mean by the non-mass?
Okay, we'll get. What? The non-mass? This picture you saw? No, it's not normal. The lateral aspect? No, it's not normal. No, not normal at all. It's a non-mass lesion. What is a non-mass when we say that? What is a non-mass, or we define a non-mass? It's a lesion in the breast. We definitely see something in the breast, but it doesn't confine to the abdomen. No, not alter. Yes, we can say it. It's something. It's a yes. It's a lesion, but not a mass. And as we said, a mass, it has to be 3D object which has a convex outer border. Yes. In non-mass describes there is a lesion, and on conscious studies we'll see that this area is taking enhancement actually, but it's not a mass. It's not a 3D space occupying lesion with margin. Okay, so we have a lateral area here, and we have this lesion. Posterior features are combined, and doctor said, I see some high echogenicity inside the mass, and this can be as if it's a hypoechoic or echogenic, and it's right. We can see these spots of calcification because we already know on mammography that we actually do have microcalcifications on the mammogram, so we can see it. As I said, we're not into looking for calcifications on ultrasound. They can be very misdiagnosing, and they can be similar to the fibrous septa of the breast. But now we already did a mammography. We know we have calcification, and we can see it here in this mass as these specks, these short specks or white lines of calcification. So when we come to categorize the calcifications, we'll say that they are inside or outside or intraductal. Actually, they are both inside and intraductal.
This related to the mammogram?
Yes, of course.
Can we match this mass and the non-mass lesion with the mammogram?
Yes, of course.
Can we see the calcification?
Yes.
Is related to the tail of the mass?
Because calcification, it's extending from the mass. The calcification. Yes, I'll get it again. Yes. Look at it again after you know that you've seen something on ultrasound. Here is the mass, and the calcifications are in front of it.
This is the tail of the non-mass lesion.
This is the mass. Yes, this is the mass, and the calcifications are extended. Yes. It's extending from the lesion. No, this is suspicious. No, this is not a cluster. This is calcification. Unfortunately, I can't see it well here, but I know the case. It's calcification. It's almost getting into a segmental pattern. It's almost triangular and just pointing towards the nipple. It's definitely going towards the nipple. No, but you have to describe the whole area of microcalcifications. You can't say, I have a cluster of microcalcifications and I still see the calcifications extending outside the mass. You have to describe the area of microcalcifications all over. What? Pleomorphic, yes. So cluster is not a morphological description. Okay, if you're asking about the morphological description, these are pleomorphic calcifications. Yes, they have multiple size, shape, density. So this is a pleomorphic calcification, okay? Segmental distribution of pleomorphic calcifications extending from our mass. So here is the mass, and the microcalcifications are extending from. And microcalcifications usually suggest DCIS. The microcalcifications say that we have DCIS, we have a mass, and we have DCIS. We're going to see the biopsy and see what happened there. Parallel. So we have, just to sum up again, we have a mass, a definite mass. It's showing flow inside. On the color Doppler, we can see that we have positive flow inside. So now we're speaking solid mass. Okay, more or less over or irregular. We have angular or microlobulated, both being suspicious lesions. We have a lateral area beside the lesion of non-mass. It's a non-mass lesion. on ultrasound. The orientation is parallel because the long axis is parallel to the skin, and we have a hypoechoic echo pattern, mixed or combined posterior features, and we have calcifications inside the mass and extending out of the mass. So we, of course, did a biopsy and we got an invasive ductal carcinoma, and we don't get just the histological type of the tumor on a pathology report, but we have the molecular subtypes, or this is what exactly we get. We get a grade 3 invasive ductal carcinoma, ER negative, PR negative, and HER2 positive. So we have to speak about the molecular subtypes of breast cancer. We cannot be doing a talk about breast cancer in 2024 and not mention the molecular types of breast cancer. So now, breast cancer is considered a group of diseases. It is not a single disease, and it's classified into molecular subtypes, which are determined by something called immunohistochemistry. So what is the importance of these molecular subtypes? They affect the treatment plan. They affect the prognosis of the patients. They prevent overtreatment with chemotherapy and cytotoxic effects of chemotherapy. Some types of these molecular subtypes do not respond to chemotherapy well, and they affect the patterns of recurrence. They are like multiple diseases under one disease entity, which is breast cancer. So what are the molecular subtypes, or the categories which breast cancer are divided into? We have luminal A breast cancer. Luminal A breast cancer is an estrogen positive cancer, progesterone positive cancer, HER2 positive or negative cancer, and low Ki67. And I'll explain the Ki67 shortly now. We test in immunohistochemistry for the receptor status of the patient. If she has estrogen, if the mass is estrogen receptor positive, if it's estrogen receptor negative, and we test something known as the HER2 receptors, which is important in targeted therapy. Now we have something called targeted immunotherapy, which is given only to patients who have HER2 positive receptor tumors. Okay, so the second type of molecular subtypes is luminal B cancers, which are also ER positive and progesterone positive, but they have a high Ki67 compared to the luminal A. We have something called the HER2 enriched type, where HER2 receptors are present. Meanwhile, the hormonal receptors, the estrogen and progesterone receptors, are not present. And finally, we have the worst of them all. The worst prognosis is with this type of cancer. It's the triple negative cancer, which means the lesion or the mass, the patient does not have estrogen receptors, progesterone receptors, or HER2 receptors. She's not going to benefit from any hormonal treatment because she doesn't have the receptors for this. Every type of these has its own radiological appearance, as we see here on this image. So the luminal cancers are usually the speculated irregular masses that we see, the typical textbook appearance of breast cancers, while the HER2 type, it can be speculated or not, but the important feature in the HER2 type is that it is usually associated with microcalcification. So DCIS is very common with these types of tumors. And for the triple negative cancers, these are can resemble the well-defined circumscribed lesions, as I was talking earlier. The lesions that can be misdiagnosed as a fibroadenoma in a lady are these type of triple negative cancers, and they are the most aggressive type. So now the biopsy of our patient today turns out grade 3, which is a high-grade cancer. We have 1, 2, and 3, and grade 3 is a high-grade cancer. It's ER negative, PR negative, and HER2 positive. So HER2 positive means usually comes with high-grade tumors. It is associated with DCIS, as we see here. We have the microcalcification, and we have the non-mass lesion on ultrasound, and it's usually multifocal. So what's the importance of knowing these things or this information about HER2 enriched tumors when we are sitting in our multidisciplinary teams? Because regarding breast, we sit with our pathologists, our surgeons, our oncologists, and we all decide on what we're going to do for our patients. So when they show a HER2 positive tumor, it is usually multifocal. So I usually suggest that we have a pre-conscious exam, a preoperative contrast exam like MRI or contrast enhanced mammography to detect any lesions that were not seen on the original lesion, on the original image. So it's very important to know about molecular subtypes because this will influence our recommendations and what is supposed to be done for patients, and not for everyone, not for every patient we will ask for the same recommendations as the other patient. Now to our third case, a 37-year-old woman with dense breast on mammography performing a screening. She's going to do a screening ultrasound anyhow. Of course, the mammography is not useful at all. She has extremely dense breasts. We can never see a cancer in these breasts. Excuse me?
Because she's below 40, right? Because her age
Yes,
is below 40.
yes, yes, yes. But it's not a rule. I'd like to say this since you mentioned it, because there's everyone says that the older patients have fatty breasts, while the younger ones have dense breasts, and the sensitivity of mammography is not that good. But it actually may depend on the patient's history, past history. So a lot of patients now are taking hormones for IVF. The gynecologists know this. They take for induced pregnancy, so they take a lot of hormones. So you can see a young patient who was under hormonal therapy for IVF or whatever, and you can, an older patient, I mean, who's under hormonal therapy for IVF, and you see her breast dense. You can see her breast test, which is expected that her breast at her age should be fatty, but this is not the rule. And on the contrary, you can see females who have got married early and they've got several kids and they've been breastfeeding. So you find their breasts, they are fatty because she lactated and she breastfed a lot. So at a young age, you can see fatty breasts. So it's not a rule. Yes, the breasts get fatty as we get older and as the age advances, but it's not a rule. You can see fatty breasts in young patients, and you can see dense breasts in younger patients too, and in older patients. Okay, so she was coming for a screening mammogram, not useful at all. We can't see anything. So it's an ACR by RAD 4, and the breasts are very dense. We do the ultrasound. So I'm doing the ultrasound, and I'm quite seeing some small, well-defined lesions. I'm under the mindset that I've got well-defined fibroadenomas. It's well-defined all around. They are small. I'm not worried about anything. They all seem to look alike. So I'm going to write a BIRADS 3. Okay, I'm going to issue a report with BIRADS 3 with multiple fibroadenomas. We just want to look at them after 6 months, and then I look at this lesion. So it's quite different than the rest. Yes, I was going to issue a fibroadenoma report, a multiple fibroadenoma report, but when I saw this one, I just started to look at it and think it over. So is there something wrong with this one? So this is the one we're speaking about. These are the other fibroadenomas. Yes, definitely. Yes, yes. So all these lesions here, they have a well-defined circumscribed margin. They all look alike, but this one looks different. Why? Because yes, it's well-defined here, but what about here? Is this well-defined? We can definitely see microlobulation in this lesion. And as I said, microlobulation is something we are worried about. We cannot just let it go. And she's going to take a BIRADS. What do you think? 3 or 4? This side 3, this side 4. Okay. Of course, this will be a BIRADS 4, because as I said, once that I'm suspicious of anything, I just can't let it go for follow-up, and I just have to raise it for a biopsy. Okay, and as we said and as we saw, it's just different than the rest of the other lesions. These are all well-defined lesions all around, but why is this lesion having these microlobulations and not looking like the rest of the lesions in the breast? So once I suspect something, I'm not going to let it go, and I'm going to raise it to a BIRADS 4, to a BIRADS 4 score or category. And surprisingly, the biopsy comes with a triple negative grade 3 invasive small ductal carcinoma and the Ki-67 here was greater than 50%. So what is Ki-67? I said that the reports include the grade, they include the molecular subtype of the tumor, and they include something called the Ki-67. This is a proliferative index. It's a measure of cell proliferation. And when we say that we have a high Ki-67, it means that it's more than 10 to 15%. And it's associated with high-grade cancers. So it gets a better response for chemotherapy because any proliferating lesion, yes, 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 any mitotic lesion, high mitotic index, it has a high mitotic index and it's proliferating, so it definitely gets a better response with chemotherapy than the luminal cancers, but it's aggressive at the end, and the prognosis is much worse. It is much worse than the luminal types of cancer. And now to the triple negative cancers. These are common in premenopausal women, and they are 15% of all breast cancers. And as I said, why did we say this is a triple negative cancer? Because of these hormonal status. Does the ER negative mean she does not have estrogen receptors? PR negative, she does not have progesterone receptors, so she's definitely not up for hormonal treatment. She doesn't have the HER2 receptors, which benefit from the targeted therapy or the targeted immunotherapy. It's called Herceptin, if you have heard about it. She won't benefit from it because also she doesn't have this receptor, and we use the term triple negative breast cancer for these cancers who don't have any receptors whatsoever, whether hormonal or HER2. And they have certain characteristics. They are more common in premenopausal women. They are 15% of all breast cancers, really aggressive and a poor survival rate. They recur usually in the first 3 years, and they send metastasis to the visceral organs, not the bone. And this is in contrary to the luminal tumors, which usually metastasize to the bone. And we all know that visceral metastases are much, much worse than bone metastasis. Now, a 40-year-old complaining of a lumpy right breast. She feels lumps in her breast. What do you see? Yes, this time we don't need magnification, I think. We can see it without magnification. And yes, within the lesion this time, yes, yes. We can see the lesion. Here is a lesion, and maybe there's another one down here. There is another one down here, and we can see calcifications related to the lesion. So she's going to ultrasound. These are the calcifications. She's going to ultrasound, and this time, because the calcifications are more clear on mammography, as we can see, they are also more clear on ultrasound, and these are the white specks here. We can see some shadowing. We can see some shadowing behind these calcifications because they are large, and this one went for biopsy. And again, it was a triple negative breast cancer, and this shows the story of that well-defined cancers or well-circumscribed cancers can be like fibroadenomas. Here we can suspect a fibroadenoma. It has the typical calcifications that we might think they are benign, but the margins definitely here are not good. We have more than 2 to 3 gentle lobulations, microlobulations. Maybe we have speculations here or angulation, but at the end they do not look like the speculated cancers with posterior shadowing. These are the lesions that can be missed with fibroadenomas once again, and her biopsy was a triple negative breast cancer. And it was a high grade. As we said, grade 3 is high, and 1 and 2, 1 is the low and 2 is intermediate grade. So when we have high grade cancers, they usually have pushing borders. So this is what we see here. We see as if there is an echogenic part around the tumor because they grow very fast. They may show enhancement. We can see calcifications in the masses that are of high grade cancers, and they can have a parallel orientation, once again resembling fibroadenomas and the benign lesions. They can be round, and of course we have to put a VIRAD 4 category, so we biopsy these lesions and know what they are. Now a 60-year-old, next case is a 60-year-old patient, postmenopausal woman coming for screening. Yes? Yes, of course, this time. Definitely not parallel. Definitely not Saturday. Okay. Okay, shadowing at the periphery a lot. Okay. Okay, so we have a density here on her mammography. Well, it's the it's as if it read the textbook of malignancy or breast cancer. A regular, yeah, it's typical. It's a typical breast cancer. All the typical cancers that we see, it's irregular, it's dense. We have speculations. We have speculations from the lesion. Okay, and when we move to ultrasound, the lesion is hypoechoic. We have shadowing behind, and we can have some speculations also from the mass. And this is at the type of cancer that we would definitely give a BIRAD 5 score for. We're pretty sure that it's cancer, but what type of cancer? I mean the molecular subtypes since I mentioned them, luminal A, B, HER2 negative or triple negative, HER2 enriched or triple negative. What type of cancer do you think this one? Okay, maybe you can't remember the type. It's luminal cancers. These are the luminal cancers. We said they are estrogen and progesterone positive receptors. This is what characterizes them. And they are the typical cancers we are used to, irregular, speculated, hypoechoic, shadowing, and a definite virus for categorization. To our next case, a 33-year-old following up of a palpable right breast mass. What do you think about this lesion? Okay. Okay. Yes, the margin. What about the margin? Well-defined circumscribed, well-defined circumscribed. So are you worried about this lesion or aren't you worried about it? Or you want to biopsy? Anyone want something else? Okay, okay. So this is a good point because actually fibroadenomas and complicated cysts can look very much alike, and both can have no vascularity. So they can look alike, and it's not a problem. At the end of the day, I say it's not that big of a problem because both will be put in the category of the virus category of 3. So both are going to be followed up. So I don't care. I know maybe that someone can write it complicated because they can look alike. Sometimes they can look alike. Okay, so this is a 33-year-old. She has her palpable right breast mass. Actually, she's been doing her follow-up and it's stationary for 2 years now. It's well defined. I have no problems with it. There is some shadowing, no problem. At the ends, this can happen. It's normal with benign lesions, but it's very well defined. It's a typical fibroadenoma. We don't have a problem regarding this lesion. What about this one? A 20-year-old with a palpable left breast mass. Yes, I definitely can't leave these borders, right? Microlobulated, if you want to say microlobulated, I'll accept up to 2 to 3 gentle macrolobulations and I won't be able to. So you find this 2 to 3 gentle lobulations or it's not 2 to 3 gentle lobulations? No, it's more than 2 to 3 gentle. We have this gentle ovulation, this gentle ovulation, but here I'm not happy with the margin here. I feel that it's not well circumscribed and well defined as this lesion. Excuse me? This needs a biopsy. Excellent. So now we're going to, yes, definitely. Once as I said, yes, once I said I can't see this bush, but once I said I am not comfortable with this lesion and it's almost like a gut feeling inside. Once I just say that my borders are not good, I'm not comfortable, and we're going to go for a BIRAD 4 and the biopsy of this lesion immediately. Okay, so it turned out to be a fibroepithelial lesion. It was not a suspicious lesion. So not all suspicious lesions turn out to be malignant. And as I said, we can very well put in, not malignant, fibroepithelial lesion. Benign lesion, it's not malignant. So yes, yes, it is. Fibroepithelial, I just got this to show you that it's very, very normal to just put a BIRAD 4 lesion and comes back benign. there's no problem. But this was right to put it 4 because I don't like the margin and I'm not comfortable about the margin. And once I feel I'm not comfortable about any of the descriptors of my lesion, I just have to raise it, and it can come back benign and it can come back malignant. But once I write BIRADS 5 in my report, if I send it and it comes back as a 4 lesion or as a benign lesion, I'm not very happy with this. I shouldn't put a 5 if it's not the typical features of a malignant lesion, as we saw on the luminal cancers and the shadowing, the irregulation, the speculation. Then we put a 4 and see what is going to happen. Okay? Yes. Yes, they use it a lot. They use it a lot. Not all the lesions are fibroadenoma. It can be under the fibroepithelial. No, it's part of the lesion. Fibroadenoma is under the categorization.
Not the mammary. The structure, the fibrous structure.
I don't know.
Mammary adenoma, sometimes we encounter maybe 5-10% of the cases. Adenoma, not a fibroadenoma.
Yes, we have a lot of adenomas. Yes, we have adenoma. We have lactating adenoma. So yes, it's under.
This is not a fibroadenoma.
No, it's not a fibroadenoma. The spectrum, the mammary gland نفسها, the mammary gland. Okay. Yes. So fibroepithelial lesion is the wide spectrum of the disease, and the fibroadenoma is under the fibroepithelial lesion. It's under the fibroepithelial lesion. We have a wide spectrum, so this came as not as a fibroadenoma, but it's one of the other lesions. And I just wanted to show you that again, if I send the BIRADS 4 and I get a benign pathology, this is not a problem at all. Now our next case, a 65-year-old with a palpable left breast mass. And I think everyone can see this mass. This is a huge mass. Can you see it? Yes. Yes. Can you see the mass? Can you spot out the mass? Yes. Yes, very good. Yes, it's very clear. It's very clear on the mammography. It's very clear that we have a well-defined rounded mass. It's a large mass. It seems well-defined on the mammography, but it's a huge mass. Now let's look on the ultrasound. Yes, this is the mass on the ultrasound. Yes. No, it's inside. It's inside the mass. Here you can see it here. It's inside the mass. This is the whole mass. So we put the Doppler on, and this is the flow inside the mass. Yes. Cystic changes inside the mass. What is this? No, not a complex cyst. No. You know why it's not a complex cystic mass? It's because the majority of the mass is a solid mass. So we better say it's a solid mass with cystic degeneration. Okay? When the lesion is, the majority of the lesion is cystic and we have a small portion of the mass, a small portion of solid component inside, this is complex cystic. But when the lesion, most of it, or all of it is almost solid, and now we have a small cystic area inside, we say that this is an area of cystic degeneration or cystic spaces within a solid mass. Okay? Yeah, of course, it's a BIRADS 4. I can never leave a huge mass like this. We have things that are quite characteristic for in this mass to make us suggest a certain pathology, which is, I'll suggest something in my report because I see this is a large mass. I see that this is a large mass with cystic spaces, and as I said, this is very characteristic for phylloid tumors. Whether benign or malignant, the imaging features are not that conclusive, and our biopsy proved it to be a malignant phylloid tumor. Well, we can't tell the benign or malignant tumors from imaging alone. They look the same. Both are well defined and both have cystic spaces. Both have positive flow within the lesion, so they're almost the same. But in this patient, this lesion had enlarged rapidly over a short period of time, and we biopsied it and we got malignant phylloid tumor. We were pretty sure that it was phylloid because, as I said, it has the characteristic features of phylloid. It's a solid mass. We have cystic spaces. This is the cystic spaces again showing enhancement, definitely solid. And these are very, very characteristic to phylloid tumor. And I would advise you, if you're doing imaging and you see this appearance, you suggest in your report for the pathologist that this can be phylloid. We're suspecting phylloid. Most of them are benign, and the malignant type is very, very rare. This was malignant. And we'll go back to our surgeons in this because they remove a wide local excision, right? Do you do this with phylloids, Dr. Surgery? Do you remove a wide local excision with the phylloid? Excuse me?
Should be with the mark.
Yes, should be, definitely, definitely, because phylloids are characterized by a high index of recurrence. So even if we have a benign pathology, our surgeons tend to remove a wide area or a wide local excision because it might recur. Even if it's benign, it might recur. The incidence of recurrence is 30% in benign tumors, while the borderline and the malignant lesions will recur with 65%. So anyhow, even if it's benign, as I said, we have to take a wide local excision to prevent the recurrence of this tumor. Okay, our next case is a 33-year-old woman has a large mass in her breast. Yes. So can you see it? Everyone can see it. Yes. I think everyone knows by now what a complex cystic solid lesion is, okay? So, and positive, exactly, exactly. And it's quite good. This lesion is actually quite good because it has a portion of the mass or a portion of the cyst, I mean, it's a bilobe cyst, and part of the cyst here is not showing flow, while the other part of the cyst is. So we're combining both a complicated and a complex cystic mass in one lesion. Can you appreciate the lesion? Can you appreciate it's a bilobe cyst, okay? Bilobe, this is a cyst. Bilobe cyst, they're just one structure. We have some sedimentation here, okay? We put the flow, and this part of the cyst is not taking any positive flow, right? Meanwhile, we have a certain part of the cyst which, when we put Doppler on, it takes positive flow. So we describe this lesion as: is it anechoic? Is it hyper? Is it iso? Is it complex cystic and solid? Okay, everyone agrees that we have to choose the complex cystic and solid lesion. No other thing, okay? Nothing to think about. It's just a complex cystic solid lesion. Why did we say that? Because this time, as you see, not like the other case, most of the lesion is a cyst, but we just have parts that are solid. On the contrary to the phylloid tumor, most of the lesion is a solid lesion, and we only have small cystic spaces within the mass, so it's described as a different entity. So we have a complex cystic solid mass, and the BI-RADS will be 4-3. What would you like to do with the complex cystic solid mass? Okay. Agree 4, or would you like to put it for a short-term follow-up? 3-4. I'm sure I'm making sure with them. They're thinking, so I'm asking. Yes, it's out of the question, definitely. This is a rule, and we follow it all the time. Agree? We have flow, which equals a solid mass, which equals biopsy, which equals BI-RADS 4. Okay? And we can see the mass. As I said, we said that this is a mass. Why? Not because of its configuration, not because of anything, but just because it has a positive flow. When I put the Doppler on, we can see a positive flow. Okay? And as I said, this is the contrary. This is not a solid mass, because if it was a solid mass, we would have flow inside. So this is just infection in the cyst, sedimentation in the cyst. It's not taking any flow, so we're not worried about this part. But as long as part of the cyst, even if it's a tiny part or a small part, takes flow, then we're into a complex cystic solid mass, and it's a BI-RADS 4. And now the biopsy comes as a papillary carcinoma. What is a papillary carcinoma? It appears one of the types of histological types. As I said, we have a difference between histological types of breast cancer and molecular subtypes of breast cancer regarding the receptor status. This time it's a histological type of breast cancer, which is called papillary carcinoma or intracystic papillary carcinoma. They appear as complex cystic and solid masses. Okay, they are not that common, more common in older women, and they don't tend to involve lymph nodes. We can see the lymph nodes are usually normal with these cases. which shouldn't put you off from putting a virus 4 category. So just to mention, we have a cyst here, another cyst. Is it a cyst solid? What do you think about this lesion?
Another one?
Yes, another cyst. Yes. What do you think about this lesion? Yes. We have to put Doppler. So we put Doppler. Yes. Positive is not positive. Not positive. Yes, hey, this is the Doppler. Look, blood is outside the lesion. Okay, so we put the Doppler on and there's no flow inside. Okay, so we have a cyst. This time we have a cyst. This one, it's isoechoic. It's kind of assuring because we have a fluid level. The infected material inside or the infective debris inside is doing a straight fluid level like this, as we can see here. But I just want to make sure that we don't have any hidden solid portions or nodules within the mass. So I just put my Doppler on, as I said, very, very easy. And we don't have any flow related to this lesion. It's a cyst once again, thin wall, posterior acoustic enhancement, no flow on Doppler, so it's a cyst. But we cannot say on this cyst it's a simple cyst. Why? Because we have echoes inside. Simple cyst means anechoic with no internal echoes at all. So this cyst we call complicated cyst, okay? Yes, peripheral, but never inside. We saw it in the BIRAD. If we have flow, it's going to be at the periphery, never inside the mass. No three. Complicated cysts are three. Simple cysts are two. The only category and the only type of cyst that we put under BIRAD 2 is the simple anechoic cyst with no echoes at all inside. Yes. Once we have echoes inside, so we're moving into the category of a complicated cyst. Yes. The first thing we have to do when we see echoes, we put our Doppler on like we did here to just make sure again. And we don't have echoes, so this is a complicated cyst and it's going for a BIRAD 3. We just follow up because these cysts tend to enlarge, they can get more infected and they can get enlarged. So we put them in a BIRAD 3 category, but we don't do anything else and it's just a simple complicated cyst. Yes, they get big sometimes. Yes, these cysts can. Yes, it's better to follow up because sometimes they can get big and can get more infected. So we just look at them, and we know that only the simple cyst, the simple anechoic cyst, is the one that we put into the BIRAD 2 category. The complicated cysts are all BIRAD 3. Okay, we don't put the rules; they put the rules, and we follow. As I said, we follow the ACR BIRAD, and this is an atlas with everything we want to know about. If we want to see complicated cysts, you can look it up. A complicated cyst is put in the category of BIRAD. Okay?
So how do you follow up this patient?
Yeah, it's like, it's the same. No problem. It remains the same. Usually they don't change, but we do what is written that we should do, so we do. Okay? Great. Okay, so now to case number 10, okay? A 40-year-old with tenderness and redness in her skin for 3-month duration and the palpable left breast mass. What do you think? Which side? The left. So what's the problem?
This is just a professional.
Yes. Without any, yes. You can do it without ultrasound. You can do everything without ultrasound. Surgeons can do everything. You don't need ultrasound, definitely. Okay, so what do we see? What do we see here? Yes. You can be a radiologist. He's our doctor gynecologist here, but he's doing very well in radiology. Okay, we talked about it earlier in the lecture. She detected it, and as she said, exactly. What about the skin in this breast? Yes, definitely the skin in this breast is thickened, and the density of this breast overall, it's more increased than the the other side. The trabeculations here are not like this side. So we have our problem where on the left side of the breast. So let's do ultrasound. What do we see?
No, no, it can be another way. Other one, which is close to the granulomatous inflammatory carcinoma.
Yes. Okay, so like doctor said, we have edema on this side. We showed edema before, and we said that the fluid in the lobules will make the echogenicity of the lobules higher. The skin is thickened. We call it a featureless breast. We can no longer see the posterior pectoral muscles because the fluid in these lobules is hindering the passage of the sound wave. So we have edema in this breast. We definitely do. And we have a mass in the breast too. And this mass was biopsied, and we got, from the mass, we got an invasive ductal carcinoma, luminal receptors are positive, no problem. And we have a skin biopsy which shows tumoral emboli in the dermal lymphatics, which is essential to diagnose an inflammatory breast cancer. Okay, so it's good we have gynecologists here because, as I said, most of the patients like to go to gynecologists first for any breast problem, and gynecologists are not usually minded with this intensity of breast cancer. So a patient goes with redness and tenderness in her breast, and they treat the patient as if it's a case of mastitis. And it's almost been not a single patient I've seen, maybe very rare patients that I've seen that has went to a gynecologist and she's suspected inflammatory breast cancer. Already inflammatory breast cancer is an advanced stage. So we want to diagnose it as early as possible, but you have to know what it is so you can recommend a skin biopsy, and you can tell your surgeons or tell your gynecologist that this may be cancer. We need to make sure, and the only way to make sure is through a skin biopsy. And it turns out that she's been treated. This is the history I hear every time from my patients with inflammatory breast cancer. She says, I had inflammation and redness in my breast. I went to my gynecologist, and he said, you have just inflammation. And I don't know why she's not referred actually for a simple ultrasound. They tell her you have mastitis, so you're going to go on antibiotics. And of course, the antibiotics do not relieve her symptoms. And she's in to one antibiotic and the other one, and maybe we can take. Yes, yes. Yes, yes, she should go to ultrasound, but hopefully she'll go to a breast radiologist who is oriented with inflammatory breast cancer. Because a lot of times she can take just a normal report of there's a mass or not a mass, and you don't suggest the inflammatory breast cancer. And this is our role, to suggest and to remind our surgeons or our gynecologists that not all redness and tenderness in the breast is mastitis. Is mastitis, and as I said, it's an advanced cancer. We need to diagnose the cancer as early as possible. And going through this scenario, which I hear every time, is delaying the patients, and it's already a stage 4 cancer. When we diagnose it with the skin biopsy, it's a stage 4 cancer, and it's advanced cancer, and she comes to us very late after her journey through the different antibiotics. We recommend a skin biopsy, and it's the only way inflammatory breast cancer can be diagnosed. So yes, very good point. This is the problem, that not all inflammatory breast cancers have a mass. 30%, 30% only of cases. This is a very good point to be raised. 30% only of cases have an associated mass, like this lucky lady, she had a mass. So if she doesn't have a mass, still I have to suggest inflammatory breast cancer even without a mass. Because no, I don't want to wait to. I don't want to wait for the patient to go to antibiotics at all. I don't. She's already there. So when I get a patient, if this patient is not in the age of a lactating breast, if she's not lactating, if she's not in the age of lactating, she's not breastfeeding, which is actually the setting for infection of the breast. If she's an old lady, because inflammatory breast cancer can come at an older age. So why should I say mastitis? I shouldn't do that. Or we can say it might be mastitis, but mastitis is not common in the older age group, and it's not common in females who are not lactating. So I simply suggest a skin biopsy, which is a very, very easy procedure, but I'm just taking care of my patient. Yes.
You cannot convince the patient. You know how we deal with the patient.
No, you can.
Because for the first time, go immediately.
Yes. We tell the patient. No, no, no. If she wants to go to another doctor, she's unlucky. She's going to another doctor. Look, this is our work. We do it every day. So
I mean, from breast time, we cannot let the patient go for skin.
yes, I'm telling you that this is our life. A patient comes for screening and she's out of the room with you're going to have a biopsy. We do it every day, not just for skin thickness, not just for redness. A lot of times the patient just doesn't have anything. Like we saw the patient with the multiple fibroadenomas, and now, no, I suspect something. So we encounter this every time. We see it a lot. It's always in our work. Whenever we put a biopsy, whenever we recommend a biopsy, the patient, especially if she doesn't have a palpable mass or something, she really feels there's a problem. But in the redness and this setting and the inflammation setting, she feels there's a problem. But a lot of times, a lot of our screening patients, they just don't feel what they have. They can have microcalcifications. Nothing felt, I don't have anything in my breast. And like you said, once we tell a patient she's going to have a breast biopsy, she's not happy at all, and she knows that this may end with breast cancer. We have to convince the patient that this is for her benefit. And we do that all the time. I insist on my patients, especially those I feel that she's going to go home and she's not going to do anything. I tell her it's a simple procedure, which it actually is. Especially, I mean, core biopsy. And we do skin biopsy. We can do skin biopsy very easily with our needles of the core biopsy. We just take a core from the skin. It doesn't have to be a surgical skin biopsy. It can just be core biopsy from the lower layers of the skin. We do that. And it comes with a positive or negative diagnosis. But we have to do a biopsy. We cannot leave an older patient who is not in the lactating state or in the breastfeeding state, and she comes with these symptoms. No, not the reproduction. She has to. Yes, yes. No reason for infection, because no, not common. Inflammatory breast cancer, no, not common in the blood. The common is the lobular cancer. Yes, it's totally different. Paget's disease is something. No, it's a nipple. There's around the nipple. Yes, it's erosion of the nipple, but there may be a mass and maybe not. There can be a mass. Yes, just like inflammatory breast cancer. So usually breast cancer equals a mass. This is a misconception, and we always try to concentrate on these rare cases so that we are always in a mindset that it's not infection, it's not mastitis, and it can be a very serious malignant disease, not just an ordinary malignant disease, but an advanced stage of malignancy. Okay, so the skin biopsy, and the only way to diagnose inflammatory breast cancer, as I said, is to take a skin biopsy through we find tumor embolus in the dermal lymphatics. As we said, the patient comes with a rapid onset of erythema, induration, warmth, and tenderness, and it should be clinically suspected, commonly misdiagnosed as breast mastitis, if not always. Okay, very commonly diagnosed as breast mastitis. And as I said, almost all of my patients who had IBC have already run through the story of multiple antibiotics which are not responding, so we decided to come to do an ultrasound. Okay, may or may not have a breast disease. Where it's an advanced stage of breast cancer, it's stage 3 or 4 disease, and at the time of diagnosis, it's already in the 3rd or 4th stage of the disease. We don't want to delay our patients any more than that, so I hope that we usually suspect it in all the cases we get with the signs of mastitis, but not in the proper setting. We advise this patient for a skin biopsy. Okay, our next case, 45-year-old who has pathological right-sided nipple discharge. So the good question now is, what type of discharge? Yes, what type of discharge, or what makes a nipple discharge pathological discharge? What is the type of discharge from the nipples which we don't like? When it's unilateral, when it's spontaneous. So we ask our patients, do you find secretions on your underwear and things like that without doing an effort to take it out? It is just spontaneous, and a lot of, excuse me? Yes, 1, 2, 3, 4. And it's bloody. When it's bloody, of course, bloody is a very bad sign. And when it's from a single duct orifice, it's not from the whole nipple. So we do our ultrasound. So what does the ultrasound show? Yes, and the lovely sign of flow and positive flow and Doppler once again. Excuse me?
Highly malignant.
Yes, yes, definitely, definitely. So we
Five,
have,
not four.
so here is the nipple. No, 5 is for the typical cancers, irregular speculated hypoechoic. This is not a mass actually. This is irregular dilatation of the duct is going into the nipple. Here is the nipple, and this is an irregularly dilated duct, okay? We have something inside the duct which once again follows the rule of the complex cystic solid masses. And how's that? We put flow, we see isoechoic content, and this isoechoic content inside the duct can be infection, which is very common. Ductal mastitis and ductal ectasia are something which is very, very common. We see it a lot. So we want to decide if this isoechoic content or the content of the duct, is it malignant or it's not, or is it a solid mass actually within the duct? Within the ducts, and we put our flow, and we can very clearly see this time that the flow is inside the ducts, and we have a solid component here. But sometimes solid components, or a lot of times, not actually sometimes, a lot of times, the solid components within a duct, it's a mass. It's definitely a mass. So we're reporting a mass, we're reporting an intraductal mass, and we're reporting a virus spore, but it can just be a papilloma, can do this, and it does all the symptoms we said now. Usually these patients are going for excision when they are symptomatic. They choose to go for surgical excision because they don't like the symptoms of blood coming out. So they are usually going for surgical excision. And there's controversy about papillomas. It's a benign lesion, but there's a high risk of this lesion to upgrade to malignancy. It's one of the pre-malignant lesions in the breast. So we excise the lesion. But very lucky, sometimes they are very small. They are very small lesions in the duct, but these are one of the most hypervascular lesions in the breast. So when I put my Doppler on the ducts and we don't have flow, or we have flow, this guides us very well towards if we actually do have an intraductal mass, which may be a papilloma, or there's nothing in the duct. It's highly vascular, so it will detect flow very, very easy. So this is another duct here. This is the duct, the anechoic duct. It's here, and this is something inside the duct. What do you think? Isoechoic content. And why did I say isoechoic? Why did I choose to use the term isoechoic here? Why did I say isoechoic? Isoechoic? Okay, it's okay. Let's say yes. Okay. Yes, very good. We don't have Doppler. Okay, so we said it's a cystic mass. So I'll say it's a linear structure. Okay, this is the nipple here. So this is a linear structure. It's a duct. So linear structures in the breast are usually ducts. It's markedly dilated, but it's a duct. At the end of the day, this is a duct. It's dilated. We have a portion of the duct anechoic, and it's very good here. It's wide, but we're not worried about it. And now we have not a hyperechoic content, but an isoechoic content, because we compare the echogenicity of this thing with the outside fat. Here's the fat. This is the fat outside, so it's exactly similar. So when we report lesions, we say that this lesion is an isoechoic lesion. Okay, so we have an isoechoic lesion. What do we do when we see isoechoic lesions? Just like the complex cystic solid massive fat. We, excuse me? Yes. We follow the rules. We follow the rules for the ducts just as we follow the rules for our complex cystic solid lesion. We find something in the duct. We want to make sure that if this is not an intraductal mass or a papilloma, we simply put on our Doppler and see. So do we have flow here?
No.
In spite the picture that it has a complex border and it looks like a mass, and this is something we very, very commonly see. The secretions can take the configuration of a mass, but this is not what we decide upon to say if this is actually a true mass or not. We decide with the Doppler. So anyone who will see this configuration will say this is definitely a mass. And I'll decide if it's a mass or not when I put my Doppler. I put my Doppler on, and we do not see any flow inside this isoechoic area. So it's secretions, and it's going for a BIRAD 3, like Dr. Sergi said. Okay. And now to our final lesion, female complaining of a palpable left mass, a 20-year-old. And here is the dimensions of the lesion. Well circumscribed. Okay. Yes, very good. Okay. And Dr. Rajali said it's a lipoma. We have a well-defined, it's a very common. We have a well-defined lesion, okay? Its echogenicity, can you see what I mean by hyperechogenic or echogenic lesion? This is the surrounding fat this time, and you can see that its echogenicity is higher than the surrounding fat, okay? So it's an echogenic lesion or hyperechogenic lesion, well-defined. It's in the subcutaneous fat, in the layers of the subcutaneous fat. So it's definitely a lipoma. It takes a BI-RADS2. It's one of the lesions which we give a BI-RADS2. Fat cells are seen within a fibrous capsule, and by examination, it's a very soft lesion, and we don't have a problem diagnosing these lesions at all. Okay, so we finished with our cases. I'll be speaking in short about magnetic resonance imaging of the breast, just some of the indications, and we'll go through quickly. I'll just take a break for 2 minutes, and I'll be back. صوتك حلو ناديني كتير لا ما اتحركتش شويه لما بتكلم كتير خلاص
لما ساعة ما جيتي حضرتك قلتي
كويس جود
But almost we are done.
yes ان شاء الله
مش فردانة؟
no fine الجو عندكم حر خالص
معقول؟
yes very hot
لا احنا لانه مش متعودين، احنا بالنسبة لنا هيك برد.
لا بس عشان حر على طول انا عماله اقول لهم في ديسمبر بتعملوا ايه؟
احنا في 50
لا
53
لا
من
بتهزري
54
مصيبه
صعبة. فيعني احنا لما نشوف
yes it's good okay
Hey, just put it. Okay, okay, this okay?
Before we start with this,
Yes,
I forget last question.
yes,
What is the rate of calcification of the breast on mammography
yes,
and the rate of
yes. It's not that common, actually. It's not that common. It's not that common. We see microcalcifications, not that frequently. And when we see microcalcifications, it does not mean 100% diagnosis of breast cancer. Yes, this is the question, 50%. Yes, it's like 50%. It can be, and it cannot be. It's the 50%. This is what we call it maximum, maximum. In some research work and some textbooks, it's 70%, but not all microcalcifications, not all suspicious microcalcifications. I mean, not any microcalcification. I mean the suspicious ones. Not all of them. Only a percent of around 70%, maximum 70% will turn out to be breast cancer and ductal carcinoma inside. In fact, these calcifications are the reason why we are doing screening mammograph. We want to detect these microcalcifications because, as I said, very commonly they cannot be associated with a mass in the breast, so the patient doesn't know, her doctor doesn't know, he can't feel it. But when she does a screening mammogram, which is doing a mammogram without having any symptoms, we can find these microcalcifications. And by the way, DCIS can remain for more than 20 years in the breast without changing into an invasive breast cancer. As you know, it can stay for a long time without changing, but this is what we do. We do screening mammogram to try to detect the cancer as early as possible so that the cure is much better. So again, we're going to do a screening MRI or a breast MRI for patients who are high risk, and these include those with a more than 20% risk of getting breast cancer, those with gene mutations or a first degree relative of gene mutation, certain syndrome, and if we have history of chest radiation to the chest, some young girls can have radiation in non-Hodgkin lymphoma. They radiate this chest for the lymph node, and this increases the lifetime risk of getting breast cancer. And its role is very important in cases of new cancer diagnosis. Once I've diagnosed the disease, I want to see the exact extent of the disease. It's very important in assessing the response of neoadjuvant chemotherapy. It's the best one used to assess this response because it shows the lesion very well, and it shows how large it is, and it shows its response to chemotherapy. And it's also useful in a certain diagnosis of occult breast cancer. What is occult breast cancer? It's pathologically proven breast cancer through enlarged axillary lymph nodes. We see it a lot. We don't have anything in the breast. We do an ultrasound, we do a mammography, and we can't find anything in the breast. But sometimes we have to take a biopsy from the lymph nodes, and when we send it to pathology, they are able to tell us that this is of breast origin. So now we're sure that we have something in the breast, but we can't see it. And this is one of the very useful indications of breast MRI, and it can really detect an undetectable small disease which wasn't seen by the other imaging modalities. And of course, best imaging modality for evaluation of implants. So the basic technical requirements, we need a dedicated breast coil. Of course, we have to give contrast except if we are evaluating implants. There is no requirement for a minimal field strength. It can be done on 1.5 or 3 Tesla, but we cannot go below 1.5. And this is an important thing that we have to know, and we have to note when performing a lot of breast MRI. We should not perform breast MRI except if we have tools to perform an intervention through breast MRI, which is not very, very common because MRIs will definitely detect things more than the ultrasound, more than the mammography. But we have to make sure that when we detect a suspicious lesion or something not seen on mammography, not seen on ultrasound, so I cannot do it through ultrasound, that I can do an MR guided biopsy. And we shouldn't be performing a lot of MRI without confirming that we have at least a referral agreement with a cooperating facility, that if we find something on the MRI, we can refer it and we can be able to get pathology and get tissue diagnosis of this lesion. So the patient, this is the position of the patient. She lies prone with her arms extended forward over her head, and her breast is hanging down in these breast coils we said before, so that we move the breast away from the chest wall to be away from the movement of the heart. And in fact, it's not a very comfortable position. And if you ask any patient who has had a previous breast MRI, she'll tell you that it is not a comfortable examination at all. It's a lengthy examination. It will take at least 30 minutes to finish, and she's lying in this position, and patients are really not happy with having an MRI. For at least 30 to 40 minutes. So it's a lengthy examination, and the patient, as I said, is lying in this position, which is not the best position ever. And we have with MRI something called pulse sequences. So what is a sequence? A sequence is a group of parameters which affects the signal intensity of the tissues, and we have several sequences. The most common sequences we use with the breast MRI are the T1 weighted non-fat, the pre-contrast T1 weighted. We have T1 weighted, some images called T1 weighted, 2T weighted images, and we have something called fat suppression. We'll speak about this now. And we use the post-contrast image, the early and delayed phases, subtraction images, and let's look at some of these sequences we commonly use with breast MRI. So the first sequence is the T1 non-fat saturated images. So let's understand what fat saturation means or fat suppression means. It means we suppress the signal coming from fat. We said that the breast is composed of fat and fibroglandular tissue, and fat can be quite a lot in older patients. So we don't want to see the signal of fat in these T1 weighted non-fat saturated images because it's important in certain cases. And sometimes we have to look at the non-fat saturated images, which means the images in which the fat is giving us a bright signal in. So when looking at the non-fat saturated images, which means we're going to see a lot of fat, and this is the fat here on mammography, we can see this is white. This is white again, on the contrary to our other two studies. Fat on mammography appears white, while the fibroglandular tissue appears dark, okay? So as you see, it's taking a large portion of the breast which is being bright, and if we give contrast and we have enhancing lesions among this white fatty tissue, it's not going to stand out good. So a lot of times we just have to suppress the signal from this fat, so the breast is dark and any enhancing lesion can be seen. But why do we look at the non-fat suppressed signals, suppressed images, or the lesions with high signal intensity of fat? These are the lesions we usually determine on it the amount of fibroglandular tissue on the breast. As we said, with mammography and ultrasound, any radiological imaging we're performing, we have to comment on the amount of fibroglandular tissue within this breast. So the non-fat saturated images are going to help us do that. And we have 4 categories. We'll speak about them shortly. And it's important to detect fat within lesions, because there are some lesions in the breast, as we said, that have fat. So I cannot do fat suppression with these lesions. I want to look at the non-fat suppressed lesions so that the signal from fat remains high and I can see the lesion. And a very common lesion is fat necrosis, which has a high signal intensity on fat. And on these images, we can see something called the susceptibility artifacts seen around this circle, which are caused by surgical clips, whether for biopsy or for surgery. It appears dark on the T1 non-fat saturated image. Now on the pre-contrast fat set, these are on contrary to the other non-fat lesions. Now we can see that we don't have any signal from fat in this breast. Why? Because we have suppressed the fat signal. So we don't see anything white except if we have an enhancing lesion, or if we have already something which is high, not because of the fat, but there is intrinsic hypersignal in it, such as the proteinaceous fluid in ducts or cysts. We can see without contrast. This is not contrast because I haven't given the patient contrast already. We can see high signal in the ducts, which happens with infected ducts. And this is why we would look at a pre-contrast fat sat image just to see any intrinsic T1 hyperintensity, such as blood or proteinaceous fluid, whether in ducts or in cysts. Now the T1 post-contrast fat saturated images, and these are the most important images I would like to look upon, and these are the ones that are different from the other techniques. But this is the first time we're going to encounter contrast in our images or in our studies, and we're just going to look for enhancing lesions. This is the most important thing to see. We also have something called background parenchymal enhancement with MRI. We see it on the post-contrast images, and we'll speak about it in the lexicon. We have enhancing lesions because, as I said, this time we gave contrast. So any enhancing lesions, we're going to see like we see here. We have enhancing lesion in this breast, and it's important. And we have enhancing lesions here. These high signal lesions we see in both breasts. These are enhancing lesions, and we can't see them except if we've given contrast on the post contrast, and we do fat suppression, because if we don't do fat suppression, these lesions will be hidden by the fat, and we won't able to see them standing out as we see them standing out on these post-contrast fat suppressed images. Okay, and we can assess for lymph nodes on the post-contrast image. Here is a lymph node. It's enhancing and large, and these are the images we prefer to look at lymph nodes on. Now to the subtraction images. Subtraction images, we subtract the post-contrast from the pre-contrast image, just to make sure that this white thing we can see, or this enhancing thing we can see, is actually a lesion. So when we do subtraction, we can see high signal intensity here, which means that we have true enhancing lesion in this breast. And it helps us, of course, in our diagnosis, in our visual inspection for the kinetics and the blood flow within a lesion. And we also do a sequence known as MIP, or maximum intensity projection lesions. These are computer-aided sequences, and we can see here that we have multiple lesions which were not seen without the MIP. It's actually very useful, and it shows the extent of the disease we have. And we do something called kinetic analysis, which is kind of unique also for MRI. So what is it? We look at the contrast when it has reached the lesion. How is it going to perform? Is it going to leave the lesion? Is it going to remain in the lesion? We look at this, and we call this kinetics. We can do it through the curves like here, or the computer-aided diagnosis. This is a computer-aided diagnosis. We look at the colors, or we assess the curves, and we can do it visually, which is most of us do, and I personally do. We look at the early subtraction. We agreed that we will do subtraction to make sure that the enhancement we are seeing is actually true enhancement, and it's just not some intrinsic T1 hyperintensity. So we look at the early subtraction images. I don't see anything enhancing here, but when we look later on, or the late subtraction image, I can see an enhancing lesion in this area, which means that this lesion has progressive enhancement or progressive kinetics. Coronal images are of importance also in MRI, very useful in looking at the internal mammary lymph node. And here is the affected lymph node on this coronal image. And we can also look at the bones of the ribs and the sternum to make sure we don't have any metastases. And the sagittal images also help us in evaluating of all nodal chains. This is an affected node. We look at the lateral aspect of the sagittal images to make sure we don't have any lymph nodes. And we have a sequence known as the T2 weighted sequence. It's an image fluid sensitive sequence. It's so anything with fluid inside, most common will be a cyst, of course, will be bright on the T2 weighted sequences. And sometimes it's one of the sequences that we usually detect affection of the liver in. And as we see in this case, we can see two intense lesions within the liver, and these were metastases. Now, just as we have a lexicon for mammography and a lexicon for ultrasound, we have another lexicon for MRI, which will guide us to describe any abnormal lesion we can find during doing MRI and revising the images of a breast MRI. So this is the biggest of them all, as we can see. It didn't fit, so it has things similar to mammography and things similar to mammography, and we have new descriptors. I'll try to go through it a bit quick. So the first thing we're going to comment about, just like mammography and just like ultrasound, is the amount of fibroglandular tissue in the breast. Any examination we're performing in breast imaging, we usually comment on this as our first comment on images. And we have 4 different types, which are an almost entirely fatty breast. So we agreed that fat on the non-fat suppressed image. This is a non-fat suppressed image, okay? Here, it's a non-fat suppressed image. I mean, this is a fat saturated image. I'm sorry. We can assess them on the fat saturated image and the non-fat saturated image. This is a fat saturated image, and once again, the amount of fibroglandular tissue is going to be the white here. We have entirely fatty. The first one is entirely fatty with no fibroglandular tissue at all. The second one is a scattered fibroglandular tissue. We have some fibroglandular tissue, but the majority of the breast is fatty. We have a heterogeneously fibroglandular tissue breast. Here, the majority of the breast, here the majority of the breast, or the greater portion of the breast, we have this glandular tissue, and there is still fat. We can say there is still fat, but when we speak about the major component of the breast, it's definitely the fibroglandular tissue, which is more. So this is described in our reports as a heterogeneously dense fibroglandular tissue. And finally, we have an extreme fibroglandular tissue, which is equal to the dense breast or the ACR BI-RADS4 on mammography. And what is the problem with mammography? We cannot see any lesion on this kind of breast or on the dense breast, but on MRI, because we give contrast and the abnormal lesions when enhanced, the dense breast do not represent a major problem for us, and we can see any enhancing lesions within this breast. Okay, and something else we assessed on the post-contrast images is something called the background parenchymal enhancement, or the BPE. I don't know if you've heard this before, or if you deal with a lot of MRIs. Do you do a lot of MRI here? Doctor was telling me you do a lot. No, not a lot?
Yes, yes.
Doctor says we do a lot. You do a lot?
Yes, MRI.
Yes, you do. Yes, you do a lot of MRI breast with contrast. Okay.
And it's recommended by radiology.
Yes.
I
Yeah.
don't know why. What do you think?
What do you think? I think against. I shouldn't be saying that. We were discussing it now. So doctor was telling me a lot of radiologists ask for breast MRI, and they delay the decision of the biopsy until to see what MRI has said. Does it say do a biopsy or not? And actually, what happens in practice is I send my BI-RADS4 to MRI, and it comes back again, and I see a lot of reports coming back to me again with the same BI-RADS4. So I send the patient for an MRI, either to upgrade this lesion to tell me it's definitely malignant, or to downgrade this lesion to say it's benign, we don't need to take a biopsy, or something, just to change my carriage. So when I send it BI-RADS4, it comes back BI-RADS4. And it's quite, as I said, it's an examination which is not tolerated at all at patients. They don't prefer doing it, let alone the financial cost. It's extremely expensive, and as I heard here, it's also extremely expensive here, and it's expensive in Cairo and in Egypt. So I try to manage my case as much as possible from mammogram, ultrasound, and I end my case with a biopsy. And when this lesion turns out malignant, then I can refer to MRI, or I refer to contrast enhanced mammography to see the exact extent of the lesion and make sure I don't have any multiple lesions and any bilateral lesions. I would do that. But I don't ask for MRI that much. And as I just said on my slides here, that no MRI should be done if we don't have equipment to let us take biopsy from what we find on MRI, because this will just increase concern and will just make the patient worried and make me worried about my patients, because I feel that there is something, or I see that there is something which might be suspicious, but at the same time, I do not have the equipment, which is not available in my country, and I don't think it's available here. There's no point to ask for a biopsy or to ask for an MRI if I can't intervene with what I find on MRI. So the background parenchymal enhancement, it describes the percentage of enhancing fibroglandular tissue in relation to the surrounding breast.
First timing to do mammo after period, right?
Mammo only. Mammo only.
Mammo.
Yes, ultrasound can be done any time. Ultrasound can be done anytime. It's not related.
You know what I mean?
Yes.
Decongested.
Yes, but this is not a problem for us in ultrasound at all. No, this is not a problem for us at all. Yes, it's a problem for mammo. Yes. Why? Because the breasts are very painful before the menses. So when we do compression views and we do MLOs, the patient feels pain. So she can't tolerate it well. It's not well tolerated by the patient. Okay? So we do the BP, as I said, it's the percentage of enhanced fibroglandular tissue in relation to the rest of the parenchyma, and we can have minimal, mild, we have moderate background enhancement. It's this enhancement we see here, the little spots here, so it's mild. We have a larger area here, which is moderate, and we have a big area here, which is the marked background parenchymal enhancement, and we are mandated to report these things: the amount of fibroglandular tissue, the background parenchymal enhancement, on all MRI reports. They should be symmetrical in both breasts. We could see them symmetrical, but sometimes we see asymmetrical here. We see asymmetrical background parenchymal enhancement, which is not the best. And now to any enhancing lesions on the breast. And enhancing lesions are characterized into three categories: the focus, a focus, a mass, or not a focus, not a mass, which will be a non-mass enhancement. So what's a focus? It's a unique dot of enhancement, typically less than 5 millimeters. If it's uniform, and on T2, I go back to my T2 images and make sure that it's hyper intense and it's uniform and we don't have a problem, we consider a focus a benign lesion, which does not require follow-up or anything more. It's seen here on the T2 weighted images, and it's well defined and uniform, so I don't have a problem with it. It's as if it's not there. Now to a mass, same descriptors of a mass. We have an enhancing mass, and as you see that the mass is higher than the surrounding fibroglandular tissue, and the shapes are the same, oval, round, and what is not oval or round is irregular. The margin, once again, similar to mammography and ultrasound, circumscribed. We can go all around the margin. The margin can be irregular, not circumscribed, but these are two O categories only, not more than two categories. They can be irregular and speculated, which are suspicious in MRI. So we've seen an area of enhancement. So a new descriptor now, we have to describe the pattern of this enhancement, whether it's homogeneous, which means it's complement and uniform enhancement, like we see in this lesion. This enhancement is heterogeneous, which is non-uniform. Not all the lesion is enhancing. Not all the lesion is enhancing. Similar, we have areas here which are not enhancing as the rest of the lesion. It can be rim enhancing, which means more enhancement at the peripheral of the lesion, as we see here, and this is one of the suspicious enhancement patterns. And we can see dark internal septations. Can you appreciate the dark internal septations? I show it here with an arrow. And it's characteristic for a fibroadenoma. It's pathognomonic for a fibroadenoma. It's well seen. We see it a lot of times, and incidentally, we can see it. We diagnose fibroadenomas with it. It's quite, as I said, specific to fibroadenomas. Now, let's talk about non-mass enhancement. And we said that it's an enhancement which is not a mass or not a focus, and its borders do not conform to the borders of a mass. And once we have an enhancing lesion, whether a mass or non-mass, we have to describe the distribution of the mass. And this is quite close to the distribution of calcifications on mammography. We have a similar term. So focal non-mass is just an area of enhancement which is very small and less than 25% of a quadrant. Linear enhancement, highly suspicious, ductal orientation. And as we said, it's as if there's a ruler or a line and pointing towards the nipple. Segmental, the same description of segmental on calcifications and mammography. It seems like a triangular area here with the nipple pointing, with the apex, pointing towards the nipple, and this also highly suspicious. Regional is not linear and not focal. It takes up a portion of the breast, a larger portion of the breast, but it's not one of the segmental, or we don't see in it segmental or linear, so we're just not worried about it that much. And we have multiple regions, small areas within the breast, small enhancing areas within the breast. As I said, not enough to be a mass. And diffuse non-mass enhancement involving almost the entire breast. So the pattern of enhancement, now we describe the distribution of the enhancement. Now we're going to describe the pattern. It can be homogeneous, which is uniform and complement. Heterogeneous, as we said, the mass is not enhancing. The mass is not enhancing in all areas the same. It can be clumped, which is kind of a complement enhancement. And finally, the clustered ring appearance, which is periductal enhancement of the ducts and carries the highest positive predictive value for malignancy. We can see rings, as if there are rings here. rings here, and the periphery of the rings is enhancing, and this is the lesion which is highly suspicious for malignancy. Now to kinetic curve assessment, as I said, I don't want to go in a lot of details regarding this curve, and we do it a lot of times visually only. We assess the initial phase of the curve, and we assess the delayed phase. The initial phase of the curve is during the first 2 seconds after we give the contrast injection, and we're going to look how the contrast is going to act. If we see that the increase in contrast, the increase in the contrast is greater than 100% than the pre-contrast images, then we say that this is a fast initial phase. If it's between 50 and 100%, then this is a medium phase, medium initial phase, and if it's less than 50, then this is a slow initial phase. We also have we also look at the delayed phase after the first 2 minutes, and after the curve changes, we see what's happening there. So if the enhancement is increasing, we say that this is a persistent pattern or progressive pattern of enhancement. If it's more or less the same with less than 10% variation in the value of the pre-contrast to the post-contrast images, we say that we have plateau kinetics. And if it's decreasing more than 10%, we say that we have washed out or delayed kinetics. The morphology is more and much more important than the kinetic curve assessment, because sometimes we don't know who's doing the kinetic curve, and we're not always there when the curve is being done, and we prefer to look at our kinetics and look at our enhancement visually than performing or looking at the curves if they are available. We have non-enhancing findings on the MRI, and I am going to skip these because we don't want to go into too much details with MRI. I want to move to the intervention section. We have cysts, we can have cysts, we can have skin thickening, nipple retraction, just the things that we spoke about in mammography. And we have fat-containing lesions. If you want to take this, just take a picture. Fat-containing lesions, the most important of which is fat necrosis. It causes a lot of problems, and we see it a lot of time. We can have hamartomas in the breast, as here. It's a mixed signal intensity lesion, well defined, and we can have seromas and post-operative hematomas. And implants by mammography, implants by MRI. This is the place where we have to do an MRI, and it's the best imaging modality for examination of implants. It detects intracapsular rupture, extracapsular rupture, and as I said, it's the best one. We use something called the silicon sensitive sequence when we do suppression to all signals, even water signal, except the signal from silicon, so we can very easily detect any lesions. Now to the common cases, we'll see just quickly some of the common cases and findings we see with mammography, we see with MRI, sorry. So a 38-year-old lady with a lump in her right breast. What do we see here? First of all, the first question is, do we have an enhancing lesion or we don't have an enhancing lesion? Yes, we have enhancing lesion. Of course, we have an enhancing lesion because this is a fat suppressed breast, no fat in this breast. Okay, and we do that in post-contrast, as I said, so we don't have anything bright in our images except the enhancing lesion. And so this enhancing lesion will stand out and we're able to diagnose. So we have an irregular. Yes, definitely rim enhancement. Why is it rim enhancement? Because the periphery of the lesion is enhancing much more than the center of the lesion. Okay, and we look at our early subtraction and late subtraction images, as I said, to determine the type of washout we have or the type of kinetics we have with this source of lesion. Excuse me? Yes, persistent is increasing. Is it increasing? Persistent is progressive. What do you think? Yes. Decreasing? Decreasing. Look at both. We look at the early subtraction and the late subtraction. What do you think? The same. So the same is definitely plateau kinetics. Okay? Yes, what do you think about it here? We look at the enhancing foci. Yes. We don't see it at all. We look at we try to see the full enhancing foci here. We don't see it at all, right? Okay. And we have to look. So we have an irregular enhancing mass rim enhancement on the gadolinium images, and on the early and late subtraction image, we have plateau kinetics. And we have to look up in the axial images to make sure if we see our lymph nodes or not. Sometimes we don't see them in the lower cut. We have to go up in the axial images to see the lymph nodes. And here we have, it's the same as ultrasound. So these are the muscles. As I said, the muscles are related to the level. This is the pectoralis major muscle, and this is the minor muscle. So here we have which group of lymph nodes? Yes, level 1, and between both muscles, 2, and inferior to the pectoralis minor 2, it's 2, and then medially 3. Very good. So here we have, just like with ultrasound, it's just a bit. Excuse me? Yes, we're still assessing the lymph nodes in this patient. We're going to go with, we're still assessing the lymph nodes in this patient. Yes, same patient. We just went up to make sure we're looking at the lymph nodes and we're not missing anything. And we see here a lymph node which is rounded, the same criteria which we follow for mammography and ultrasound. We'll follow here that a rounded lymph node is seen very clearly here, which is an abnormal lymph node or an affected lymph node. And the diagnosis was, of course, an invasive ductal carcinoma, which is the most common type of histological breast cancers. It usually presents to us with rim or inhomogeneous enhancement, as we see here, and they come with washout curves, but sometimes some of these lesions do not enhance to that degree, and we may have a homogeneous enhancement and we have plateau instead of washout kinetics. This is very common. We see this. And I want to mention the golden rule in breast MRI, which I just said, that the morphological features of concern should, if you have morphological features of concern, you should not let plateau or progressive enhancement put you off. So if we're going to choose something to decide with whether morphology or kinetics, and we feel that the morphology of this lesion should have washout kinetics, but we're getting a plateau or even a progressive enhancement, we don't let this affect our decision, and we see something irregular, we just put a BIRAD 4 or 5 for the lesion, and we're worried about it. A high-risk 45-year-old patient having a screening MRI. So we also look at the gadolinium, the early subtraction and the late subtraction images. So what do we see here? Can we see enhancing lesions? Enhancing lesions, bright lesions. Do we see enhancing lesions? Yes. Yes. So we definitely see on this side here, we have enhancing lesions or bright lesions, which is not a mass. This is not a mass. This is linear enhancement. This is sort of linear enhancement, maybe segmental, pointing towards the nipple. So this is what we describe as a non-mass enhancement. We have another enhancing lesion here at the lateral aspect of the left breast. And we're going to look at the kinetics of these lesions. The peripheral lesion, which is the non-mass lesion, the kinetics seem more or less the same. Maybe there's some washout kinetics, but the lesion here definitely shows washout because it's high on the early subtraction, but on the late subtraction, it's definitely not enhanced. So this one definitely has a washout kinetic, but it seems it has a thin, smooth cortex, and the center of the mass, which appears high on the gadolinium or the T1 weighted image, is not seen on the subtraction image. So this is intrinsic T1 hyperintensity, and the center of the lymph node is already high, not because of the enhancement, because it was lost on the subtraction images. And this actually, when we went back to her ultrasound and mammography images, it turned out to be in intramammary lymph node. So ductal carcinoma in situ. The common appearance of ductal carcinoma in situ on breast MRI is non-mass lesions and plateau enhancement. It's not always washed out. It appears as a linear, segmental, or clumped heterogeneous enhancement. And MRI is very useful when we have non-calcified DCIS. We can see some calcifications on the mammography, but when we do MRI, we see the exact extent of this disease and the extent of the non-calcified portion of the DCIS, which is not seen on mammography. This is a 39-year-old diagnosed with left-sided breast cancer. So she came to us, and we know that she has left-sided breast cancer. What do you think? There's a striking feature. We know the cancer, we can see the cancer. We have a striking feature in this case. Yes, the skin. This time the skin is thickened, as we see here. The skin is thickened, and not only is thickened, it enhances too, okay? In a patient who has not had post-operative radiotherapy, sure, she hasn't radiotherapy, it's her first presentation, she's diagnosed with cancer, but we can clearly see that the skin is thickened and it's enhancing as well. We do our MIP images and look at the extent of the disease in the left breast, and The sagittal images also show us that we have affected lymph node on this side. Yes, yes, it's on T1 to make sure this is a fatty hilum or not a fatty hilum, but they intense vigorously on the post-contrast images. So again, inflammatory breast cancer, the important finding in MRI, which is not seen on the mammography, of course, is that we have skin enhancement and we have thickening, but we have enhancement as well. And we definitely won't be able to see enhancement on the mammography images. We have enhancement of the Cooper's ligament. And as I said, inflammatory breast cancer is not a radiological diagnosis. We just get to know it so that we are able to suggest such a diagnosis. It requires a skin biopsy to be diagnosed. But it's our role to suggest that this might be inflammatory breast cancer and this actually requires a skin biopsy. Okay. Yes. This, excuse me? Yes, yes. Okay. No, next slide or before?
The same slide.
Okay. Yes.
Go back.
Back again?
To the back. The left. No, no, no.
Oh, next. Yes, yes.
What more?
Okay.
One, two.
What is this?
And
I can't see. No, this is not a lymph node. Lymph node enhances, it enhances.
I'm talking about thermometer. But this is a shadow. This is inflammatory. No comment. Is this a shadow of a mass?
No, it's not a mass. I'll show you on the other images. Look.
You got my point?
Yes, yes. It's not a lymph node because lymph nodes enhance. Look at this image. Can you see this image, this sagittal image? This one here. This is a sagittal image. Can you see how lymph nodes are seen on MRI?
This is axilla.
Yes, this is axillary because it's
about
concentric. Internal memory is not here. Internal memory. What? No, no. Background parenchymal enhancement, we use mild, moderate, and severe. We don't use the. No, no, this is not this is mass enhanced. This image here, I'll tell you. This image here, I got it for the skin. I just wanted to show you the skin. But look at the sagittal. Look now on the sagittal image. Can you see the masses? We have masses. We have. Yes, we have masses, not mass enhancement. Yes, masses, multiple. Yes, yes, definitely. Her breast has multiple masses. This is not non-mass enhancement. Okay, I got this. This is fibroglandular tissue, by the way. I just got it. Yes, I just got it to show you that the skin thickness and the skin enhances. Okay, and this here on the sagittal image, we can see multiple masses, enhancing masses, and we see on the lateral image of the sagittal image, we see the lymph nodes, these enhancing lesions here, and lymph nodes enhance markedly. Affected lymph nodes will enhance markedly on MRI. Okay. Okay, I'll go again. Yes. Yes.
Direct my attention, there is kind of, as if there is an erosion in the chest wall.
This here? Yes, yes. I think it's the cuts. I think I can see it, yes, but I think it's the cuts. Yes. I think it's the cuts. There's no erosion. It's just the cut. The cut showed that. Yes, yes, but it's nothing here. Yeah, the next cut they will be seen okay. Because I didn't get more than this.
Then my question will be after
Yes.
is the logic and the mechanism of the plateau
Yes.
or the washout of the curve.
Yes.
I want to have some comments.
Yes.
After we finish your
Okay, we'll speak about it when we finish. Okay? If you want to say we're okay.
the kinetic curve.
Yes. So we see a lot of post-operative patients we see a lot of post-operative patients on MRI. This is a patient who has, I'll just show several cases quickly. So this is the scar. This is the scar of the operation. Okay. And now we have a rim enhancing lesion here in the breast. It seems as a rim enhancing lesion on the gadolinium or contrast enhanced lesion. It's quite irregular. It's not the smooth ring shape we would accept. And on the subtraction, we still see that sort of enhancement. So it seems that we have enhancement. But look now on the T1 non-fat SAT image, which means the fat signal is still there, no problem with that. And inside the lesion, we see an area which follows fat that's outside. Yes, yes. And we definitely diagnose fat necrosis here. So fat necrosis, here it is. This is the fatty breast. This is the signal of fat. And inside here, Inside here, this is the thing we see, and we know now that we are dealing with fat necrosis, which can show enhancement or some degree of frame enhancement, but we diagnose with very, very high confidence that this is fat necrosis, and we don't want to do anything else regarding it. It's common in post-operative patients, and it's sort of a troublemaker for us on mammography and ultrasound. It's a sort of a troublemaker for us on mammography and ultrasound, but MRI is good and it solves this problem. Now another post-operative patient. So this is her operative bed, and we see a rather speculated. This is her operative bed, and we see a rather speculated, not very good looking lesion in her operative bed. So we have to decide. It's low on T2, on T1. These are pre-contrast image without contrast, and now we move to the post-contrast image. First question, is it enhancing or not? Just a question, is this lesion enhancing or it's not enhancing on the post-contrast images? Is there enhancement or not? Okay, let's look at, this is enhancement, so this is the liver enhancing here, and we compare it to any enhancing lesion, whether the heart or whether the liver. So of course this tissue here, so of course this tissue here is not enhancing, because this is enhancement and this is not enhancing. So we diagnose it's ugly looking and it's speculated, but no enhancement in it. So it's definitely post-op. Yes, it's definitely a surgical scar. Another post-operative patient. Here we have low, just like the other case, it was low insignia intensity on T1, low insignia intensity on T2. Now look at the contrast image. What do we have? Here, yes, definitely we have a nodular irregular enhancing lesion, which says that we have, this is going to be what? Yes, no other option. So when we have tissue that is not, enhancing, it is fibrous tissue, and when we have enhancing tissue, then this is recurrent. And we can see here this time we have also thickening and enhancement of her skin. But why is that? Is this inflammatory breast cancer? Excuse me? Post-op, yes, she's post-operative. So this thickening, what's this thickening caused by? It's caused by radiation. Okay, radiation-induced mastitis, and this is very common. We know why the skin is thickened. It's not like the cases of inflammatory breast cancer. We are sure that this is because of the radiation. No, it's not related. No, 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 no. No, it's radiation-induced. Okay, this is radiation-induced, and this happens almost in all the patients who take radiation therapy. It's not accepted if the patient hasn't had radiotherapy. I always ask her, did you have radiotherapy or not? And if she didn't have radiotherapy, I am concerned regarding this finding. I don't just let it pass. As I said, I would go for a skin biopsy in cases of inflammatory breast cancer. But when I ask the patient and I have history for her doing radiotherapy, I know that this is caused by her radiation. And another thing we see in post-operative patients, should it have this gone? Okay, it's written here, very, very common, and I think our surgeons know very well that seroma is the most common post-operative complication we see with post-operative breast, and it can last for several years, for several months and years. Do you agree with me, doctor? Seroma. Yes. Excuse me?
The seroma can be entrapped and it has a wall off.
Yes.
The walling off happens, it will last for more than a year.
Yes, yes, we see patients a long time after post-operative, and then they come and we.
There is a wall off.
Yes.
The hematoma at the beginning.
Yes.
It will end up with a wall.
Yes.
And this will last for some.
Yes, yes, yes.
And the patient doing well, maybe we aspirated.
Yes, I was surprised to see seromas a long time after surgery. I thought it was only in recent time after the surgery, but we see it all the time. Yes, yes, we see it a long time after surgery. We see it. Yes, yes. So on the contrast images, there seems to be some sort of speculated enhancement out of this lesion, outside the lesion, which can make us worrisome, especially that she's an operated patient. But we look at our T2 images, which we agreed upon that these are water-sensitive images. Okay, and the stir also is a water sensitive sequence. So we see that this lesion here shows bright signal on the T2 and bright signal on the stir, and we are very confident that this is a post-operative seroma and we don't have any problems with it. Yes. Okay. So as we said, for post-operative findings, we mentioned them and we went through them. Fat necrosis is very common, a troublemaker on other imaging modalities, but MRI it's solved. Residual malignancy or recurrence, the scarring, and all post-operative scars should not enhance after 6 months post-operative. We can accept some degree of enhancement in early post-operative patients up to 6 months. But after 6 months, this is not accepted at all. We should see no enhancement of our scar tissue, whatever. And we see a lot of post-operative seromas. Now to an accidental discovery. No, this patient, I mean, had a lump in her left breast. Very characteristic, very characteristic. We diagnose and we're pretty sure about our diagnosis. So, yes, we have dark internal septations, which we showed on the lexicon. So we're confident that this is a fibroadenoma because it's pathognomonic for the dark internal septations are pathognomonic for fibroadenomas. And when we look at its kinetics, here we're looking at the kinetics. This is the early subtraction. It hasn't taken contrast, so it has a late initial phase. And then at the late subtraction images, we see that it has enhanced. So this is kind of a progressive or persistent enhancement without looking at the curves. Just the visual inspection will let us determine this type of kinetics of this lesion. And fibroadenomas, as we said, are well-defined typical lesions, homogeneously enhancing lesions, and the dark internal septations is pathognomonic for them. And our last case in MRI, a very common finding, cysts, multiple cysts in the breast. We have these lesions, and as we said, they are water filled, and we have sequences which are sensitive to any structure which is water filled. So here is the T2 weighted images, which have high signal intensity on both breasts. We're pretty confident that we have cysts and we don't have any problem. They usually don't enhance. We don't see any enhancement. Maybe the fluid is high content inside. It's not a simple cyst, but we don't have any enhancement. Maybe just a thin rim of regular enhancement around the cyst, but nothing serious or nothing to worry about at all. And we diagnose fibrocystic changes in these breasts very easily. Okay, we'll take a quick idea about contrast enhanced mammography. It's an advanced digital technique. It's typical to a mammograph, but after we give IV contrast, and it detects the abnormal enhancement, whether the contrast enhanced mammography or the MRI, they depend upon the idea of abnormal contrast uptake by breast cancer cells, because the breast cancer cells produce new vessels, and these vessels are weak, and they have spaces in between them, and their membranes are not well formed. So the contrast leaks from these cells into the surrounding tissue, and that is what we try to detect when we give contrast, whether with contrast enhanced mammography or with MRI. And the technique of contrast enhanced mammography involves taking two sets of images, the low energy images, which are taken at a lower energy level, and they resemble the mammography exactly. And we take the high energy images at a higher kVp or a higher level of energy, and then we subtract the pre-contrast image from we subtract the low energy images from the high energy images to get these recombined images. We call them the recombined images, which are actually the images which show the contrast uptake, and they are the images of contrast redistribution. And as I said, contrast enhanced mammography, we suppress all in the recombined images, we suppress all the tissues, and only the enhancing lesions are standing out. So this is a mammography in a patient where we cannot identify the lesion at all, but once we suppress the surrounding parenchyma, we can clearly see an enhancing lesion, and that is what contrast does. It makes enhancing lesions and suspicious lesions stand out very well. And the low energy images are typical to the full field digital mammography. So any patient scheduled for a contrast enhanced mammography does not have to do a prior mammogram. Well, I'll just get through this quickly. lexical is very close to MRI. We use the mammography lexicon for the low energy images, and we use the MRI lexicon for the enhancing lesions, or the recombined image. And we just have some differences, like removal of the descriptor of the dark internal septation. We do not use this descriptor with the contrast enhanced mammography because we find that this is very fine detail which cannot be appreciated on the contrast enhanced images. We also comment about the lesion conspicuously, the contrast, is it low, moderate, or high? And we have something called enhancing asymmetry, which is enhancement on one view only and not on the other view. Let's look at some cases quickly. A 46-year-old lady, pathological proven left breast cancer, invasive ductal carcinoma. These are her pre-contrast images, and her recombined images show the left breast invasive ductal carcinoma, a heterogeneously enhancing mass. But what else? We have a small focus here in the right breast, which was not seen on the mammography at all, and it lighted up only on the contrast images. And we were able to see them on ultrasound. So now instead of a unilateral disease, we have bilateral disease. And this is a lady with a left breast lump. I think we can see clearly the left breast lump in this image. It's seen. So is it the only lump there, or do we have other lesions which are hidden behind the fibroglandular tissue within the breast? We do our contrast and see, and there it is. We have this lesion, the one we already saw with the mammography, and now multiple small lesions are seen around this lesion. And now, and so this was just a unifocal lesion. Now, of course, it's a multifocal breast cancer, and management is different. And another case showing the same idea. We have lesions here seen on the mammography film. Are these all our lesions, or do we have other lesions? The contrast shows that we have other small lesions, and we have another enhancing small lesion in the left breast here, which were not seen. These lesions and the enhancing lesion in the left breast was not seen, and turned out to be other foci of DCIS and breast cancer in this patient. A patient presenting, a 47-year-old presenting with a left breast lump. So we see something here. There's an asymmetrical density in the upper outer quadrant of the left breast, and there are associated calcifications. So let's look at her contrast enhanced, and there it is. Once again, we have non-mass enhancement, just like on MRI, and look how contrast showed us the exact extent of the disease, how big the disease is. It was not just a focal asymmetry or an abnormal asymmetry on mammography. This time enhancement, it follows the rules of MRI, and this triangular enhancement with the apex also pointing towards the nipple. And this was proven to be DCIS. And it's very important for surgeons to see the exact extent of disease before the patient goes to surgery, because otherwise the margins will be positive. If we do surgery without doing a contrast study, the margins may be positive, and the patient will have to go for research. And another case of contrast enhanced mammography, we see the lesion here in the right breast, inner quadrant of the right breast. It's well seen on mammography. Do we have any other lesions? Great. Contrast enhanced mammography helps us to say that this is a unifocal disease. We do not have any extra enhancing lesions within the breast. We can diagnose this with very high confidence. So breast reports now. We have to write the indication for examination, the description of the breast tissue, as we said. We describe any abnormal finding we see, enhancing lesions, whatever. We have masses, we have microcalcification. We have to describe it. We compare to previous examinations, which is not very common for patients to come in having their prior examinations. But if they have it, we try to do this as much as we can. And finally, we put our BI-RADS assessment category at the end of the report, which comes with the suitable recommendations. And the most important question, as I said, is, are you going to send this patient for follow-up, or are you going to cure this lesion, which moves us to our interesting subject of interventional breast radiology, which is the cornerstone of breast management. Yes, I do that. Of course I do it, yes. No, I put by that. No, I separate it. So if I have cyst and I have a suspicious lesion, I'll write that I have suspicious lesion and this is a virus 4, and I'll write another line saying that I have cyst, which is a virus 2. Yes. Yes, yes, yes. Yes, yes, I write everything. I say I write breast suspicious lesion at say 10 o'clock. I can have a lesion at 10 and 2 o'clock. Say we have two lesions. I'll write breast 10 o'clock suspicious lesion by at 4 and another lesion. Say write breast breast 3 o'clock lesion and I'll put a by at 3. I describe every lesion and every yes, every breast separate and every lesion has its own description. Okay. So, okay, now we'll move to interventional breast radiology, the cornerstone of breast management. So we do a lot of things, and it's really, really something very, very important that every breast radiology should be able to do. And biopsies, as I said, is cut a long story short. It gives us a precise and accurate diagnosis, and the story is ended. Is this a malignancy or not? Is it a benign lesion or not? And of course, it's less invasive than the surgical biopsy with the same degree of accuracy. It gives us all the information we need. And the choice of imaging, what are we going to use for the intervention? It depends on the size, the lesion, the location, the availability of the imaging technique. As I said, if we find things with MRI, suspicious findings, and we don't have the equipment to do intervention MRI, we cannot go for MRI. And it also depends on the personal experience of the radiologist. And we have various or multiple guidance methods, such as mammography guidance, ultrasound guidance, and MRI for those lesions which are only visible on MRI and not visible on mammography or ultrasound. And the first guidance is through mammography, and we do it for microcalcifications because we don't see the calcifications except on mammography. We can try to attempt to see them on ultrasound, but sometimes we don't be able to do that. So we have to do a stereotactic biopsy or a mammography guided biopsy. This is its name. It's a stereotactic biopsy, and when we take the biopsy out, we take an image of this biopsy to make sure that the calcifications are within the tissue, and we call it a specimen radiography. The best way to guide intervention is through ultrasound. We said it's safe, it's available, it's everywhere, and we do it in our normal ultrasound clinics. We do not have to go to a hospital. As I said, it's a minor procedure, and it's safe, it's quick, it's not expensive. We have color Doppler to see the vessels so as not to hit something without the intention to do so. And of course, it does not involve any radiation. Before the biopsy, we communicate with the patient because these patients are very anxious and very worried. Most of these patients coming for biopsy, they are afraid of getting a cancer diagnosis, and we take an informed consent, of course. We check her coagulation profile, and every facility has its own coagulation profile, but patients on aspirin usually continue on the aspirin. We don't have to stop their medication, but those on anticoagulants, we'll see their INR, and accordingly we will decide according to which type of biopsy they're doing and according to the levels. And it should be done under complete strict asepsis. So breast intervention procedures, we can do procedures which are diagnostic, like cyst aspiration or taking biopsies, and we do this through two ways: fine needle aspiration, cytology, or core biopsy. We can do intervention as part of a therapeutic management, trying to help our surgeons in non-palpable lesions or small lesions or lesions which have received neoadjuvant chemotherapy and can no longer be seen. And how can we help our surgeons doing that? We do something called implanting markers. We have two kinds of markers. We'll speak about them now. And finally, sometimes breast intervention procedures can be therapeutic, and we can remove small tumors, small, well-defined tumors less than 2 centimeters through vacuum-assisted removal of small tumors. So the first thing we do, we'll go to cyst aspiration. It's indicated if the cyst is symptomatic. If we have large cysts, of course, if we have implants, because we don't want to injure our implants with the needle. And we do it in simple cysts, of course, or complicated cysts. But complex cysts, we said we have a solid component, so the solid component is going to be a target for core biopsy. And we can take fine needle aspiration cytology. It's the most rapid and the most inexpensive of all types of procedures, but it gives a lot of false negatives, and it can differentiate invasive from non-invasive cancers. And of course, we can't do with fine needle aspiration cytology, we have a major disadvantage that we cannot do immunohistochemistry, and it does not determine the molecular subtypes, which I said is something very important now. We don't just have breast cancers, we have several types of breast cancers. And the tissue biopsy, not the fine needle. The fine needle was a cytological examination. Tissue biopsy is a histological sample, and this is actually what we do most of the time. It decides whether the tumor is invasive or not, and gives us the grade and the types of breast cancer, and it gives us the molecular subtypes, just exactly the same information which a surgical biopsy would have given us. So techniques for approaching the lesion, and we're speaking now about the perpendicular approach. And perpendicular is putting the needle perpendicular to the axis. The long axis of the needle is parallel, to the long axis of the probe, as we see here. Both are parallel to each other, and this is not what we do, because we see the tip of the needle only, not the whole length of the needle, and this is not safe. And as Dr. Sergi was just telling us, that it can sometimes penetrate the chest wall and muscles, and then we get pneumothorax and we get complications. So this is not what we prefer to do at all. We prefer this technique, which is the oblique technique. The long axis of the needle, the long axis of the needle is parallel to the short axis of the probe, and by this way we can see the needle from the point of entrance of the needle into the lesion all the way through, and we parallel the chest wall so as not to injure any structure beneath the lesion. Here we can see the whole, this is the needle, and we can see the whole length of the needle as it goes in, and we see as we take the biopsy, so we're sure we're not going to injure anything. And we have a golden rule which makes our life easy when we're doing intervention. The needle and the central ultrasound beam must be in the same plane, so that we know that we are going in the right path, and we can take our biopsy very easily and safe. And this is what I mean when I see the needle like this. This means that it's in the central ultrasound beam, and I'm in the right position and the correct position. I can see both the mass and the needle. So where shall we take a biopsy from a lesion? We usually take from the periphery of the lesion, because this is the maximum cellularity, and the central portion of the mass might have necrosis. For partially cystic and solid nodules, we would biopsy the solid part. And if we have a cystic lesion with thick irregular wall, which we want to take a biopsy from the wall, we will aspirate the biopsy first, then the margin. The devices we use with our intervention, we have automated devices and vacuum assisted devices. The automated devices include the reusable guns, and the reusable guns, we get needles for the gun, but the gun is not disposable, only the needle. And we have the disposable needles. These are the ones that we use with every patient and we don't use again. And finally, we have the vacuum assisted core biopsy devices, and this is the one we use to remove small tumors and in therapeutic management of some patients. This is the technique of the needle. So the needle goes in a sheath, and then the sheath has a bevel. When we fire the needle, this bevel cuts the tissue, and the tissue falls in this depression. The sheath goes out again and covers the part of tissue we took, so as not to fall while it's going out of the patient. And we actually take a good core of tissue. This is very good, and the pathologists are very happy with our cores, and we take more than one core. We usually take 2 to 3 cores, so that the specimen would be enough if this patient turned out to be cancer, and the pathology needs to do immunohistochemistry. Then when we take more than one specimen or more than one core, it's more than enough for the pathology to do what they want to do and the investigations required for the patient. And now our role as a part of therapeutic management and helping our surgeons, as a lot of masses can become non-palpable, and the surgeon is going in and he's going to remove the tumor bed even after neoadjuvant chemotherapy. We're removing the bed anyhow. So what do? We just put a clip or a metal marker in the lesion. Here, this was done for a patient with neoadjuvant chemotherapy, because once she starts her chemotherapy, we can see complete disappearance of the mass after 1 or 2 doses of the chemotherapy. And as I said, surgery will remove the tumor bed. So we put a clips in to know where the tumor was, and the surgeon to know where to remove the tumor bed. After we put a wire in there to guide the surgeon to the area where the clips was present. And the other type of metal markers is the wire. It has a hook, so we introduce the needle and we push the wire. It hooks to the lesion, and the wire comes out of the patient, and the surgeon follows this wire to go into the mass and remove the mass. Injections, we try to mark our lesions with injections. We have two types of injections, radioactive colloids and stains. The radioactive colloids have the problem that these are radioactive materials which require a radioactive camera and require certain certain precautions and safety procedures which are only present in the nuclear medicine department. And we have stains like patent blue and methylene blue. Patent blue may cause anaphylactic shock. Methylene blue diffuses rapidly, and we want to mark the area we don't want it to diffuse. And the carbon is the best of both of them. We use it a lot now in our practice. It's very good. It does not, there is no shock and there is no diffusion. It localizes in the lesion and there's no diffusion. I'll get over this. And I'd just like to say that the European Society of Breast Imaging recommendations for breast intervention say that training requires 20 procedures per each type of guidance, just to make sure that you know how to do them under supervision. And to maintain your competency, you need 25 procedures per year. And we actually do 25 procedures a week in the place where I come from, and in our hospitals we do a huge amount of interventional radiology. And finally, we'll come to a breast cancer screening. So till now, we don't know why cancer affects a person and does not affect another person, but we know that we have some risk factors that increase breast cancer, and these factors include just being a woman. Any woman is at a risk of getting breast cancer, and it's a disease of women, more common in women. Every 100 females that will get breast cancer there will be one man who will get it, so it's definitely not a disease that is common in men. And as age proceeds or gets older, or the patient gets older, the incidence of breast cancer is much common. So before 40, only a limited percent, but now we're seeing much, much earlier breast cancers in the late 20s and early 30s, and after 40, 95% of the disease is present. And it can be inherited and non-inherited breast cancer. Only 5% of breast cancers are inherited, and the rest is not inherited. And what do we mean by inherited breast cancer? It is cancer which is transmitted through a gene. And in our case here in breast cancer, it is the BRCA gene, our BRCA mutation gene. And these are the genes that Angelina Jolie had. She found that her mother was affected by both breast and ovarian cancer, and her grandmother had also breast cancer. So she decided to do the test, and she turned out to be a BRCA positive patient. And she took the wise and hard decision of bilateral prophylactic mastectomy, because this gene mutation is the highest known risk in breast cancer, and it means that if someone has it, it means that she will be getting breast cancer with a 98% possibility of this in her lifetime, which is very, very high, and it's the highest of all factors. And since we get half of our genes from our mother and half of our genes from our father, so this gene mutation can be transmitted through the paternal or the father side of the family. And the first degree relatives which we worry about are only the mothers, sisters, and daughters. And as we said, the paternal side is important, so fathers, brothers, and sons are also important. And inherited gene mutations, when do we suspect it in our clinical practice? We suspect it when there is more than one first degree relative. As I said, the mother, sister, or father or brother have breast cancer. One female relative that diagnosed at a very early age, and if this patient has also ovarian cancer, we highly suspect that there is an inherited gene, and the male relative with breast cancer increases the possibility of gene mutation, and we ask these patients to be tested. So some factors, estrogen is not a good hormone for us. It's not a good hormone for breast cancer, and a female should not remain exposed to estrogen for a long time without progesterone or without anything to suppress it. So we have contraceptive pills, not good for the breast. Human HRT or hormonal replacement therapy, also not good because of estrogen. Overweight is not good because estrogen is produced in fatty tissue. All these factors affect the estrogen within the body, which, as I said, is not good for the breast. And how do we assess the risk of breast cancer? We have cancer assessment tools on the internet, like this tool. Just some questions the patient answers, and at the end we decide the lifetime risk. It depends on how many factors she has, who is affected with breast cancer in her family. And at the end, as I said, we get a 5-year risk of 1%. For example, what does this mean when we get this risk? It means that 1% of women who have risk factors similar to yours will develop breast cancer over the next 5 years. So screening recommendations for breast cancer. We have many societies. Everyone comes with its screening recommendations. The American Cancer Society, Society of Breast Imaging. So generally speaking, we follow the ACR recommendations for screening breast cancer, which says that all females should have an annual screening mammography beginning at the age of 40 with no upper age limit. But for the high-risk women, we have a different schedule of screening. If she has positive family history, she has to do, and she has to start her annual mammography not at the age of 40, but 10 years before the age of the first relative who got cancer. If she has a BRCA mutation, she has to start also mammography early, but she's going to alternate her mammography with MRI. So we can have mammography, and after 6 months we do her MRI, but we don't start before the age of 25 in case of BRCA1, and not before the age of 30 in case of BRCA2, and other risk factors such as history of radiation. Between 20 and 30, as we said, they should take their screening mammography earlier than 40 years. And why is all this fuss about early detection of breast cancer and all the efforts done for early detection of breast cancer? It's because the 5-year survival rate for a woman with a stage 0 or stage 1 breast cancer is almost 100%, and this decreases to about 22% for a woman if she's diagnosed with metastatic or stage 4 breast cancer. And we've finished. And I always like to thank my associated staff and team in Ain Shams University, my nurses, my technicians. They are of great help in achieving my work. I can never do my work, and we all aim at helping our patients. I always like to thank my family who always support me, and I always take my back. And thank you for being with me. My phone number, my email, and I can receive messages and questions about breast imaging 24/7, anytime. It's my pleasure having you. Thank you.
Pleasure really to have you with us today. Thank you so much.
I take it back.
We are the last two. The last warriors.
Everybody
Nervous.
was
The last
apologized.
warriors we are.
Every